very good evening to everyone who's joined today. This is the 11th edition of the CMRE International Symposium in Diabetes. And I think all of us know Dr. Chawla and I have been conducting this symposium every year. And every year, I think we're growing from strength to strength, all thanks to all our faculties, delegates, listeners. And we're very happy to collaborate with the Arabic Association for Study in Diabetes, AASD, under the able leadership of Professor Inas Scholthout. So I welcome AASD as our partners in this meeting, and I think this is our collaborative meeting continuously for the fifth running year. And Dr. Mohammed Hasnan has been our partner in this, along with Dr. Colin and a lot of other faculties. So on behalf of my co-director and co-scientific chair of this program, Dr. Rajiv Chawla, I welcome one and all. I can see Dr. Maria, Dr. Jetwani, Dr. Meena, Dr. Amr El-Milgi, and a lot of other faculties who are logged in. So a warm welcome to all of you, and thank you so much for sparing time and being with us in this 11th edition of the International Symposium. This is going to be a 3 days program. So today we have the AASD and CMRE joint symposium, which is a virtual event. Tomorrow, we again have a DIPSI symposium with CMRE from 3 to 6, followed by a physical meeting in Delhi at the Lalit, a joint symposium with ACE and CMRE. And I welcome all the faculties in Delhi to join us tomorrow physically at Hotel Lalit for this symposium. Day 3 is again a physical meeting, which would again be at Lalit, starting from 9 till about 5 o'clock. And I welcome all of you to join us for this international symposium and the grand academic feast that we've all planned for everyone here. With that, I welcome one and all, and I hand over to Dr. Rajiv Chawla for a few words of wisdom as my co-director at CMRE. Sir, you are muted. Please unmute yourself.
Yeah. Good afternoon to all the dignitaries on virtual dais, all those who are logged in from India as well as from Middle East and Egypt. It's my proud privilege to welcome you all to this international symposium, which we have been organizing. This is the 11th edition of the symposium, and it is for last 4 to 5 years that we have partnered with ASD for this joint symposium. Thanks a lot. We express our gratitude to Professor Enas, Professor Mohammed. Professor Enas, she is President ASD, and Professor Mohammed Hasnain, who is based at Emirates, is also currently serving as vice chair for ASD, and we really value their partnership from bottom of heart. This program, fortunately, is getting more and more popular over the years, and this can be assessed from the fact that we have already registered close to 4,000 delegates for the virtual program, and we had to close our physical delegates registration last night because we exceeded more than 1,000 delegates for physical registration. So that talks about the popularity of the program. This year, like every year, we have drafted a very excellent scientific program along with our scientific co-chairs, Professor Inas, Professor Mohammed, those who are part of our organizing committee, along with Dr. Colin and my co-director, Dr. Shalini Jaggi. And I'm sure as it proceeds, this is going to be close to 3 hour symposium today, which will be then followed by 4 international talks by luminaries from USA. And I'm sure all those who are logged in, the delegates and the faculty, they are really going to get huge benefit, not only in terms of getting better insight into management of diabetes, but also a lot of thought-provoking ideas are going to come from these presentations because we have a battery of top international faculties listed for today. So with that small, brief introduction, I cannot see yet Professor Mohammed and Professor Inashi messaged that I'll be shortly joining. I wanted them to be part of this brief inauguration, and if Dr. Inas or Mohammed has joined, I'll request them to give their good wishes and blessings for this program. Do we have Dr. Mohammed or Dr. Inas? He has joined.
No, sir.
Okay, so we can straightway start the scientific proceedings of the program. May I invite Professor?
We still have about, let's just wait for another 2-3 minutes because we can start at 3:20, I think.
Mohammed said that I am at mosque for prayers. My lecture will start, so I'll
Okay.
join late.
Because, okay, so we can
Dr.
start
Inas
now.
also said
Okay.
that
Professor
I'm
Amri
joining
is
late.
here, so you can start.
Yeah, so I think let's not wait and start the program timely. And may I request our first chair for the program, that is Professor Abdul Khalim Hamid, yeah, who is professor and consultant hepatology and diabetes, Military Medical Academy, Egypt. Professor Abdul Hamid, are you there?
No,
Professor?
I don't think
Okay.
he's
Then I
joined yet.
request Dr. Shalini, our co-chair for CMRE ASD program, and she's also, I am sure she doesn't need any introduction, but just she is still serving as chair-elect for Research Society of Diabetes in India, Delhi chapter. She is a governing council member for Diabetes in Pregnancy Study India group, and we have been together organizing these international symposium for 11 years. Actually, this is the 11th in sequence, and I'm happy to have Dr. Shalini as chair for this present session. Over to you, Dr. Shalini.
So thank you, sir. And I hope my co-chair joins us very soon. Maybe RX, you can just contact him and see. Meanwhile, it is my proud pleasure and privilege to have our first speaker from AASD, Professor Amr El-Meliji, who will be talking on a very important topic, setting the context for glucose, weight, or vascular protection. What should be my priority? To introduce him, he is the Emeritus Professor of Medicine, Diabetes and Endocrine Faculty of Medicine at Cairo University. He's been the former head of Department of Internal Medicine, Cairo, and former head of Diabetes Endocrinology, Clinical Nutrition and Metabolism Division. He's the director of Diabetes and Endocrinology Clinic, Faculty of Medicine, Cairo University, 2009 to 17. Currently, he's the vice president of our partner, AASD. He graduated from the Faculty of Medicine, Cairo University, and worked as an internal medicine resident, resident, assistant lecturer, assistant professor, and then professor internal medicine since 2006. He has a master's in 1990 and MD in 1995 in internal medicine from Cairo University. His principal area of research in diabetes and endocrine, and published many researches in diabetes and endocrinology. He's edited a lot of chapters on diabetes and endocrine in internal medicine textbook, MCQ books, problem solving books at Cairo University. He's also a member in Egyptian Society of Internal Medicine, reviewer in ESIM and Medical Journal of Cairo University. He's been a referee in professors and AP promotion committees from 2010 to 20. A lot of accomplishments to his credit. So welcome, Professor Amr, and let's have you as our opening batsman today. A very, very warm welcome from India.
Thank you for this presentation. I appreciate this so much. I sent the lecture to the committee. Can they share me?
Yes, okay, please. Tuti, can we have his lecture, please?
Good evening. I am pleased to participate in this great conference today with you. In the following few minutes, I'm going to speak about relationship between type 2 diabetes and cardiovascular disease and obesity, changing the paradigm of the management of type 2 diabetes, and I will present 3 case scenarios. Cardiovascular disease is the leading cause of death in persons with type 2 diabetes. One person with type 2 diabetes in 3 has cardiovascular disease. Risk of hospitalization for heart failure is 2 to 5 folds in individuals with type 2 diabetes less than 55 years versus those without diabetes. A person with type 2 diabetes without previous history of myocardial infarction has 7 years incidence of myocardial infarction that is equivalent to a person without diabetes who developed myocardial infarction before. Obesity prevalence is progressively increasing all over the world in the last 3 decades. 1 billion people globally estimated to be living with obesity by 2030. In MENA regions, obesity prevalence is especially high in Gulf countries, Egypt and Libya, with rates exceeding 30%. The presidential initiative 100 Million Health in Egypt reveals that the prevalence of obesity in adults is 50%, 40% in men, and 6% in women. Obesity is the strongest risk factor for developing prediabetes and diabetes. Obese persons have six-fold chance to develop type 2 diabetes. This graph shows increasing body mass index is associated with progressive increasing in the risk for developing type 2 diabetes. Obesity and diabetes are independent risk factors for atherosclerotic cardiovascular disease and heart failure, and their combination greatly enhances the cardiovascular risk, what's called diabesity. The etiology is multifactorial and is shown here in the figure. The paradigm for the management of people with type 2 diabetes has been changed in the past few years due to understanding multiple underlying pathogenic mechanisms of type 2 diabetes and appearance of new drugs targeting these mechanisms. Emergence of two groups of glucose-lowering drugs, GLP-1 receptor agonist and sodium glucose transporter 2 inhibitors, some of them have proved cardiovascular and renal protective benefits beyond the glycemic control in cardiovascular outcome trials. Realizing the role of obesity in increasing morbidity and mortality in people with type 2 diabetes and the emergence of novel anti-obesity medications and advances in metabolic surgeries. The paradigm for the management of people with type 2 diabetes has changed from the glucocentric approach to management of multiple risk factors to the holistic person-centered approach. Regarding glucocentric approach, the UKPDS trial showed intensive early glycemic control was effective in reducing microvascular complications and myocardial infarction, but not other vascular diseases. In the ACCORD, ADVANCE, and VAD trials, late glycemic control was not effective in preventing macrovascular complications or protection from other cardiovascular events in those with established atherosclerotic cardiovascular disease. So the benefits of intensive glycemic control on the prevention of macrovascular complications after several years of uncontrolled hyperglycemia are lost due to build-up of a negative metabolic memory. Intensive multiple risk factor control. In the STIMO2 trial, intensive control of different risk factors, hypertension, dyslipidemia, hyperglycemia, and RAS blockers for albuminuria resulted in absolute risk reduction in major adverse cardiovascular events and revascularization by 20%. That's to say, residual risk exists. This is a holistic person-centered approach to type 2 diabetes management in the SD-ADA consensus for the management of hyperglycemia in 2022. This consensus aims to prevention of complications and improving quality of life in people with type 2 diabetes. Holistic means comprehensive. Person-centered means management plan is designed according to the person characteristics, needs, and considering the person as a partner in decision making of his management plan. Holistic, as I have mentioned, comprehensive, that covers the different aspects of diabetes care, including management of hyperglycemia, um weight management, correction of cardiovascular risk factors, cardio and renal protection, in addition to promoting healthy lifestyle, education, attention to mental health and psychological support. Now, let's go back to the question that is the title of the lecture: glucose, weight, vascular protection. What should be my priority? To answer this question, I will present three cases with type 2 diabetes with different clinical characteristics. Case 1, Ahmed is a 35-year-old sales representative. He's newly diagnosed with type 2 diabetes during annual medical checkup. Clinical examination, heart rate 88, regular, blood pressure 120 over 75, BMI 26, chest, heart, abdomen examination are unremarkable. Fundus examination normal. Further examinations, the fasting glucose 133, postprandial glucose 208, and A1C 7.7%. GFR, TSH, liver functions, CBC, iron creatine ratio, lipid profile, all are within normal. ECG is normal. Which one is priority in the management of Ahmed? Ahmed is recently diagnosed with type 2 diabetes, has no other atherosclerotic cardiovascular risk factors except slight increase in his weight. His BMI is 26, which is expected to decrease with proper lifestyle intervention. He has no target organ damage. My focus here is glycemic control. Uh, we can start with lifestyle intervention plus metformin monotherapy. We can also consider starting with early combination therapy, for example, DP4 inhibitor and metformin, to avoid therapeutic inertia that may result in deterioration of his glycemic control and makes him liable to the development of chronic complications of diabetes. Early glycemic control in people with type 2 diabetes reduced microvascular complications, and metformin reduced risk of myocardial infarction in overweight and obese persons and improved survival in the UKPDS trial. These benefits continued till 44 years after commencing of the study. Before choosing antidiabetic drug, we have to set the person A1C goal. A1C less than 7% is recommended by ADA in most people. However, more stringent goals in young and recently diagnosed healthy persons are preferred if can be achieved without hypoglycemia. In elder people and those with short life expectancy and at risk of hypoglycemia, less stringent goals are preferred. Also, we have to know his A1C level to choose the anti-diabetic agent with an efficacy that can achieve the individualized goal. According to most guidelines, we start with metformin, except if contraindicated or not tolerated. Combination therapy is started if A1C is 1.5% or more above the individualized person goals. However, commencing early combination therapy with drugs with low hypoglycemia risk and with different mechanism of action, example, DPP4 inhibitors, metformin combination therapy, even in people with lower A1C to avoid inertia, is a good option to ensure long-standing optimal glycemic control, and also is useful in delaying the need for insulin treatment according to the results of the Verify study. This slide shows the efficacy of different antidiabetic agents on glucose lowering. We have to choose the drug with efficacy that can achieve the individualized goal. Most guidelines adapted the stepwise approach in the management of type 2 diabetes, which is intensification of treatment when the patient loses glycemic control. However, this exposes the patient to long periods of hyperglycemia due to therapeutic inertia, and this will lead to the development of chronic diabetic complications. On the other hand, early combination therapy using drugs targeting different pathogenic mechanisms of type 2 diabetes offers early sustained glycemic control, preservation of beta cell function, and lower risk for developing chronic complications. Case 2. Mrs. Radwa, 42-year-old housewife, mother of three, the youngest is 4-year-old. She had gestational diabetes in the last pregnancy, and diabetes persisted after giving birth. She started to gain weight with repeated pregnancies. She tried many weight reducing programs for the last year without response. Her treatment is glyburide and metformin. Physical examination is unremarkable except for increased BMI 33 kg per meter square. Lab investigations are within normal. Her A1C is 6.6%. Which one is a priority in the management of Radwa? Weight reduction is the only concern of Radwa. Her A1C is 6.6%. She has no evidence of target organ damage, so management of weight is my priority. Regarding management of Radwa, first we have to determine obesity-related morbidities. Also, we have to set here individualized weight management goals. Counseling here about healthy lifestyle is important. However, I prefer to refer here to center specialized in weight management because she struggled with weight reduction in the last year without response. When choosing glucose lowering medication, avoid drugs with weight gain potential. She is receiving glyburide, and so my suggestion is to discontinue glyburide. Consideration of medications for weight loss. Now the novel drugs, incretin mimetics, are preferred as GLP-1 receptor agonist and GLP-1 GIP receptor agonist are for their dual and weight reducing efficacy. Consideration for metabolic surgery is early now because she didn't try pharmacological therapy. Regarding the efficacy of drugs used for weight loss, classified into drugs with very high efficacy as semaglutide, 2.4 milligram weekly, tirzepatide, which is GLP-1, GIP-1 receptor agonist, 10 and 50 milligram per week. Drugs with high efficacy include dulaglutide and liraglutide 3 milligram per. Pharmacological therapy is recommended in individuals who have a BMI of 30 or more or 27 kg per meter square with an obesity-related comorbidity who failed lifestyle and behavioral interventions. What are the benefits of weight reduction in type 2 diabetes? 5 to 10% loss of body weight has a beneficial effect on glycemic control. Weight loss of 10 to 15% or more can induce diabetes remission. Beyond blood glucose reduction, weight reduction reduces the risk for weight-related complications, improves the risk factors for atherosclerotic cardiovascular disease and quality of life. This slide shows the results of 3 clinical trials addressing the efficacy and safety of incretin mimetics. Liraglutide 3 mg per day, semaglutide 2.4 mg once weekly, and tirzepatide 10 and 15 mg once weekly in adults with overweight or obesity and type 2 diabetes in addition to lifestyle intervention. In the select trial, liraglutide added to basal insulin resulted in 6.5% reduction in body weight after 56 weeks trial, the duration of the trial versus 1.7% with the placebo. In the step 2 trial, Semaglutide resulted in reduction in body weight by 9.76% versus 3.4% with the placebo. The study duration was 68 weeks. Tirzepatide 10 or 15 milligram in the Surmount trial resulted in reduction of body weight by 13.4% when given 10 milligram once weekly, and by 15.7% when given 15 milligram once weekly versus 3.3% with the placebo. The trial duration was 72 weeks. This change in body weight was associated with improvement in waist circumference, blood pressure lowering, improving lipid profile, and decreasing inflammatory marker, high sensitivity CRP. Case 3. Mr. Hussam, 59-year-old accountant. He was referred to diabetes clinic after recent discharge from hospital. Hussam was admitted in CCU since 5 days with acute chest pain and submitted to coronary angioplasty. 3 stents were placed. He has diabetes and hypertension since 5 years. He is a heavy smoker. He is treated with vildagliptin metformin, combination therapy, glargine, and prendoprel. Rosuvastatin, aspirin, clopidogrel were added during hospital admission. Physical examination was remarkable only for increased BMI 34.5, left ventricular hypertrophy, and non-proliferative retinopathy on dilated pupil examination. Laboratory investigation revealed uncontrolled diabetes A1C is 7.6, and his lipid profile is elevated. GFR is 88, and iron creatine ratio is normal. Regarding Hussam, what should be the first priority in his management? Hussam has coronary heart disease, obese, hypertensive, smoker, dyslipidemic, and his diabetes is uncontrolled. All of the following are needed: glycemic control, cardiovascular protection, weight management, correction of other atherosclerotic cardiovascular risk factors as lipids, hypertension, and smoking cessation, in addition to adding antiplatelet. Regarding people with type 2 diabetes and established cardiovascular disease, GLP-1 receptor agonist or sodium glucose transporter 2 inhibitors with proven cardiovascular benefits should be added regardless the degree of glycemia and whether the patient is receiving metformin or not. Our patient is receiving D4 inhibitor, so we have to stop to discontinue D4 inhibitor before starting GLP-1 receptor agonist. Also, I prefer to use GLP-1 receptor agonist in the doses used in the management of weight because our patient has high body weight, high BMI, in addition to intensive lifestyle intervention. Also, management of other cardiovascular risk factors is recommended as blood pressure lowering, lipid lowering, antithrombotic agents, and smoking cessation. Sodium glucose transporter 2 inhibitors and some GLP-1 receptor agonists have demonstrated cardio and renal protective benefits in people with type 2 diabetes with established atherosclerotic cardiovascular disease and in those with atherosclerotic cardiovascular disease risk factors. Data from meta-analysis of many cardiovascular outcome trials on GLP-1 receptor agonist and sodium glucose transporter 2 inhibitors revealed a comparative benefit in the reduction of major adverse cardiovascular events with both, while sodium glucose transporter 2 inhibitors use was associated with more effective renal protection and was highly effective in reducing heart failure hospitalization. Conclusion: with the emergence of the novel antidiabetic drugs, especially incretin mimetics and sodium glucose transporter 2 inhibitors, great changes have been developed in the management of people with type 2 diabetes. People with diabetes are heterogeneous, and so their management priorities should be based on the individual clinical characteristics for preventing morbidities and improving quality of life.
Thank you so much, Professor for that very beautiful justification to the topic, which clearly tells us that it cannot be a single approach targeting either glycemia or weight, so it has to be a holistic management. I will request you to please stay back for the discussion once we are done with the first three sessions. And I'm so happy to welcome Professor Inas, who's just joined us. A very, very warm welcome from India, ma'am. So good to see you today.
Thank you very much. My pleasure always, Professor Shaleen.
Yeah, so we missed you in the beginning, but then maybe we can just have 2 words of your support as good wishes for this symposium. We've been partnering together for so many years now, and it's such a pleasure to have you and collaborate with AAST.
Thank you very much.
I welcome you on behalf of CMRE, and I request you to say a few words of wisdom and good wishes.
It's our pleasure usually to continue this collaboration between Egypt and India, represented by our association and your association. It's really getting more collaborative, more widespread among Egyptian and Indian and other parts of the world doctors. We have, I think, thousands of doctors attending each meeting. Part of the meeting is virtual and part of the meeting is physical. I'm not lucky this year to join the physical event, but sure, I'll be very happy to join next year physical meeting. And welcome to all doctors, attending doctors, and thank you very much, Professor Rajiv and Professor Shalini, for taking the effort to do this excellent work.
Thank you, Professor Inas. It is wonderful having you. During our initial introduction, we put it on records, our gratitude to you as well as Professor Mohammed. You have been partnering with us for last more than 5 years, and this is the 11th International Symposium in Diabetes being organized year after year, and I'm sure it is getting very, very popular. You are part of our organizing committee and our scientific chair, co-scientific chair also, and I'm sure the deliberations by all your colleagues from ASD are going to be extremely awesome and wonderful for all the delegates, those who are logged in from India as well as from Middle East and Egypt itself. So thanks a lot for your blessings, good wishes for this entire program. Of course, we are unlucky that we'll be missing you this time physically on Sunday, but nevertheless, we have 2 keynote lectures from you, which I'm sure are going to be extremely useful for all the delegates who will attend our conference physically on Sunday. So once again, thanks a lot from bottom of our heart, and over to Dr. Shalini to conduct the scientific proceedings further.
So thank you, Inas ma'am, for joining us, and please stay back with us for this program. I now have the proud pleasure and privilege of inviting our next speaker, Dr. Mohammed Hasnain. All of us have known him. He's been with us for the last 11 years in our journey of CMRE. A very, very warm and a very, very down-to-earth, a very humble person and an excellent speaker. He will be talking on the prevalence of prediabetes and diabetes in expatriates living in Dubai. All of us have known him because of his work in the IDF DAR. He graduated from the Faculty of Medicine, Alexandria, Egypt. He's a consultant in the Department of Endocrinology and Diabetes in the UK, 2002, co-founder of the Diabetes Diploma and MSc from Cardiff University, UK since 2007. He's currently serving as Professor of Medicine at the Mohammed bin Rashid University, Dubai, and a senior consultant in endocrinology and diabetes at the Dubai Hospital, and honorary professor of medicine at the Gulf Medical University, UAE. His main research interest has been in the field of diabetes and Ramadan, and he has n number of publications on this topic. He's co-authored recommendation papers on this subject from the ADA, right from 2005 to 2010, and for the British Medical Journal, Diabetes Canada, as well as the IDF DAR Practical Guidelines 2016 and 2021. He's also very interested in educational programs for people with diabetes and or HCPs, where he's won the first prize for this from Diabetes UK as well as by the EASD. He's participated as first author and co-author in numerous studies, regional and international guidelines, including studies on prevalence of diabetes, obesity, hypertension, and is first author of the Emirates Cardiometabolic Guidelines. He's published more than 100 papers, a great academician, associate professor of the Dubai Diabetes and Endocrinology Journal. So welcome, Dr. Mohammed.
Good afternoon, Assalamu alaikum. Great to be with you all. And it's yet again another excellent program by the joint efforts of the CMRE International Symposium and the Arab Association for the Study of Diabetes. Delighted to be with all of you, and thanks for the kind introduction. My topic is related to the prevalence of diabetes and pre-diabetes, where I currently work in Dubai. And it's really important that we start to understand the person that we treat after all. So why Dubai? Or why UAE? Well, as you can see, that the expatriate population in UAE, the vast majority of it is people from the Indian subcontinent, and specifically from India. It's more than 38%. And people from Egypt constitute over 4%. So all in all, between people from India, Pakistan, and Bangladesh, as well as the Middle East, constitute well over 50 to 60% of the UAE population. When I compare the adult population of UAE and Egypt, according to the population figures mentioned 4 or 5 years ago for both countries, you can see a very similar population pyramid, where the prevalence of people in the older age is there. Of course, there is a sizable proportion of the population in the younger population. But this is very different from the population in Dubai. As you can see here, the population in Dubai, in the dark blue is the national, in the light blue it's the expatriates. And it is very clear that the expatriate population is far much bigger than the local population. And indeed, specifically for those who are in the adult age, the working age, the 0 to 34 years of age, as well as the adult population from the age of 20 onward, the vast majority of them are from expatriates, and specifically far much more males than females. And that's something important for us to remember when we look into our data. So we are dealing here with a much younger population that's living in the country in comparison with the local home countries. As you can see, the bulge in the expatriates living in Dubai and Abu Dhabi are very young working age people, where in home countries, of course, there's a sizable proportion of people above the age of 60 up to the age of 90. So with that in mind, it's important to understand the reality, the numbers. The numbers shows that whether it's Egypt or Middle East or the Southeast Asia, the Indian subcontinent, the expectation for the rise of prevalence of diabetes is pretty high. 96% in North Africa and Middle East, and 74% in Southeast Asia. That's a massive rise considering the high population of both regions. When we look into the prevalence of impaired glucose tolerance or pre-diabetes, equally, that region is one of the highest prevalence of glucose intolerance. When we look into the latest information from the IDF region, specifically for India, you can see that over 9% are expected to have diabetes, and the prevalence of pre-diabetes is equally pretty high as well with impaired glucose tolerance. Now, it's quite interesting that when we look into data from India, similar to the Gulf and in Egypt, the expansion or the increase in prevalence of diabetes and pre-diabetes is related to wealth. And here you see the GDP, and as the GDP across the different states increase, the prevalence of diabetes triples between what you can see here and what you can see here. So that's also very important. If I would expand to look into the expatriates in Dubai, and a part of it, of course, is many people from Pakistan, and this is the data that's been published 6 years ago about the prevalence of diabetes in Pakistan, you can clearly see that the prevalence is getting higher and higher, 14% pre-diabetes and 24% diabetes. We have looked into this in Dubai with a WHO style of survey of screening for many health issues, including diabetes and pre-diabetes. And as you can see, the total prevalence of diabetes in UAE is 13.7%, and it's a lot higher between nationals compared to non-nationals. But of course, the big issue is it's a problem related to age. And as we get older, many of us will have diabetes or pre-diabetes. But the worrying concern in the country is the high prevalence among people in their early 20s or late teens, as well as people in the age of 25 to 44 years of age. Now, if I were to look into further data on dissecting this information between expatriates and nationals, whether it's pre-diabetes or diabetes, you can argue that is over 30% of the expatriate population have either diabetes or pre-diabetes. The figures here, the gray column and the yellow column, when you add them up together, it is well above 30% of the total population of the expatriates. So 1 in 3 nearly of expatriates would have either diabetes or pre-diabetes. This is the pre-diabetes data from the same style of screening program and survey done for 2019 and just been published earlier this year. And as you can see again here, the pre-diabetes in the latest survey of 2019 in expatriates and non-nationals is higher at 17.1% in comparison to 12% of Emiratis. So while diabetes is more in Emiratis, pre-diabetes is more in non-nationals. Now, it does look like it's something related to the style of living rather than just the genetics. First, I remind you again that I've shown you that the data from Dubai as per nationality, roughly 37% of Dubai population or UAE population are people from India. And as you can see that the prevalence of diabetes in India, or these people are of more or less the same genetics, but the difference in prevalence, for example, between India and Mauritius is 3 times, or nearly 3 times, because of the change in lifestyle. So clearly the lifestyle, and obviously here, the prevalence of diabetes in India is 8.9%, while I've shown you in the expatriates population, it is the pre-diabetes is 17 and diabetes is 13%. So much higher, which indicates that it's the effect of the environment that we are thinking. And this is very clear. The Delhi, Dubai, Alexandria, they have changed a lot over the last 60 years. Urbanization is the prevailing feature now. And with urbanization, there is a rise in obesity, there is a rise in increased intake of refined carbohydrates, which all impact on the metabolic parameters, and with a sedentary lifestyle, and of course, with the increase in economic development, which is, while it's welcomed, but what is not welcomed is the side effects of the problem. So we have seen an increase in obesity globally. And part of it is to try to understand the impact of this on our health, and it's the type of food that we're eating, the quantity, and the sedentary lifestyle, which is the cause of the problem. So talking about the lifestyle, the sedentary lifestyle. Here in Dubai, we have seen this of the number of people who are physically active on a daily basis of 10 minutes is not more than 17%. And when we look into people doing more physical activities such as running every day or playing football for just 10 minutes, this goes down to 5%. And that has its impact on the level of prediabetes, whether in Emiratis or in expatriates, but the rise is even higher in expatriates, as the comparison between the active expatriate and the less active person is over 2.5 times. And that's really is a major concern. And this is what we've just published, as I mentioned, a few months ago. So if you start looking into the different ages, of course, when we're young, we are more active. And here it reflects on normal weight. So while in people in their 20s, 62% of them are of normal weight, when we get to the 45 or 60 plus, it goes down to under a quarter of the population, and the rest are either overweight or obese. This obviously reflects on prevalence of diabetes as well. I've shown you this data, but now I'm showing it to you not similar pattern between the obesity and the physical activity. So here is those are not physically active, and the prevalence of diabetes in the expatriate population of them is 15.5%. When you go to the prevalence among expatriates who are obese, it is 20.5%. So equal problem between the obese person or the over the inactive person in the prevalence of diabetes among that population, diabetes or pre-diabetes. And that's obviously is quite a worry. So is related to the expatriate population, which is largely people from the attendees of our conference from India, from Egypt, and from similar countries. Going to Egypt, the prevalence of diabetes, unfortunately, is not less at all than Dubai. So the increase in wealth and the sedentary lifestyle has affected people from my home city, Alexandria, in this important systematic approach in a study to look into the prevalence of diabetes and pre-diabetes. So what can we do? Looking further into data, recent data from across the whole country on an initiative related to a massive checkup of over 60 million persons across the country, which was done at random and led to the information that obesity is BMI over 30 is among 36% of the population, which obviously is quite a concern. Consuming less than 5 servings of fruits and veg is unfortunately 90% of the population. Not engaged in vigorous activity is 79% of the population. So clearly there is a problem. And when we go to data from India, from Chennai, done by our very good colleague, Professor Mohan, and you can see that the sedentary lifestyle or the urbanization rather, leads to more central obesity, which obviously reflect on prevalence of diabetes of 11.3% versus 0.7% in rural areas where they have less abdominal obesity and more physical activity. I acknowledge that the data was 2007, but it shows that this pattern has been ongoing for some time. Again, my concern is not about the prevalence in those who are age 60 or plus, but about the young people who we are seeing across, among the expatriates, 13% prevalence of diabetes in those who are aged between 36 and 45, and even 4.5% among those who are under 35 years. So you wonder that how much is the problem of complications in these people who will live with diabetes for 40, 50, or even more years of life, and what would be the impact. Getting diabetes in my 60s or 70s probably is not, or certainly is not, as aggressive with rates of complications as someone who will live with diabetes for 30, 40 years or more. So of course we have to do something, because it does look like as we get older, green becomes less and less. Green is normal glucose level, and orange and blue is either diabetes or pre-diabetes, and it does look like 80% of those who are above the age of 60 have one or the other problem. So we need to stop the problem, and stopping diabetes is the motto that everyone is trying to do. In UAE, we developed a consensus guidelines on the management of diabetes, and we have said we need to screen everyone. And because of the data that I've shown you about the high prevalence among young people, we have recommended to lower the age of screening to those who are as low as 30 years, with one additional factor on top of being overweight or obese, because of the concern of the prevalence of diabetes. And of course, the advice is everyone with pre-diabetes needs to be provided with a comprehensive lifestyle modification program. Unfortunately, this is very rare. We need to think of 10,000 steps could be done on a daily basis, or at least 150 minutes of vigorous exercise per week. But the question is, how many are indeed doing this? And whether our cities in Egypt and in Dubai are prepared for this and equipped for this. This is the IDF and the European network recommendation for what is a city that would be scored high in the efforts of diabetes prevention. Suitability of outdoor environment for sports, the access to healthy food, access to drinkable water, education on healthy choices in schools, implemented prevention policies, and accessible information of healthy choices. Many of these items are unfortunately very deficient in many of our cities. So all of this obviously is a challenge, because changing lifestyle needs a huge amount of motivation and a very good amount of education about change and how to sustain change. Sustaining change is key. Sustaining change is indeed the difference, as we saw in the Look Ahead trial, between what happened in the first year. As you can see here, every single parameter improved: weight, waist circumference, physical fitness, glycated hemoglobin. But in the trial, as the intervention was only for 1 year, once the sustainability of the intervention stopped, gradually things got back to the control group with almost identical levels or identical figures, regardless of what the parameter is. So prevention can work if we can sustain it. And of course, that would need a lot of support for the person who has prediabetes or obesity. So ladies and gentlemen, in conclusion, the prevalence of obesity, prediabetes, and diabetes in MENA, as well as in expatriates living in Dubai and indeed in India, is pretty high. The prevalence of obesity, as well as prediabetes and diabetes, is very strongly related to age, eating habits, and physical activity. We urgently need structured plans to address these problems, and these plans need to be large-scale plans that would address the population. One of the key factors is lack of physical activity, and which appears to be indeed very important, and obviously several stakeholders need to combine together to address this. This is definitely, there is a need for a wake-up call to stop diabetes and indeed stop pre-diabetes. We cannot stop diabetes if we cannot stop pre-diabetes. And finally, I'll leave you with photos of my beloved home city, Alexandria. Thank you, and looking forward to be with you over the program, the very rich program that you have over the next, over today and the next 3 days. Thank you.
Thank you, Professor Mohammed, for that very enlightening session. And we'll have the discussion once we're done with the next speaker. So kindly stay back for the discussion. With that, I now welcome my partner, my co-director at CMRE, Dr. Rajiv Chawla, who will be talking on how Southeast Asians are at a greater CV risk. We've heard about how diabetes differs, the prevalence differs when it comes to pre-diabetes and diabetes in expatriates in Dubai, how ethnicity has an important role to play. And now we're going to have Dr. Chawla talk to us on how Southeast Asians are at a greater CV risk. I think all of us know him very well. He's been past president RSSDI, past president DIPSI, currently senior diabetologist and director at North Delhi Diabetes Center. He's also editor-in-chief of the IJDDC, the official journal of RSSDI, and he's editor-in-chief, editor also of the 5th edition of RSSDI textbook and the RSSDI annual casebook 2020, approved DNB teacher and guide, numerous publications to his credit, multiple orations and awards to his credit. So with that, Dr. Chawla, let's have it from you on how Southeast Asians are at a greater CV risk.
Thank you, Dr. Shalini, for kind words of introduction. And may I start straightway with my topic?
Can you please be a little louder?
Can you see my slides?
Yes, make it in slide share.
Okay. Can you see my slides?
Yes, sir.
Okay, I'm audible also?
Yes.
Okay. Thanks a lot. Thank you, Dr. Mohammed, for setting the stage for rising prevalence of type 2 diabetes, not only in India, in Southeast Asia, in Emirates, and also a couple of studies, very interesting studies coming from Egypt. So one thing which was really enlightening for us was not only we in India at a greater risk, we once we migrate, we are even at a greater risk, maybe whether we are in Emirates, whether we are in UK or in US. A lot of studies have come even from UK that in spite of the fact that we share almost the same environment, even after 20 years of being in US or UK, still we stay at a greater risk for developing type 2 diabetes. So I think with that, and you said that out of total Emirates population, still almost 37% of them, they happen to be Indians when it comes to overall prevalence of type 2 diabetes in Emirates is concerned. Not only that, let me tell you that we as Asians or Indians are not only we are at a little higher risk for developing diabetes, maybe 1 or 2 decades as compared to Caucasian, but also at a greater risk for cardiovascular disease once it comes to linking diabetes with CVD also. So this is how is going to be my flow of the talk, whether Asian or Indians, they are more prone to diabetes and its complication, whether there is a link between diabetes and coronary artery disease, which worsens overall mortality in these patients. What is the missing link? Is it higher consumption of carbohydrate contributing towards postprandial hyperglycemia, contributing to higher CVD in Asians or in Indian patients, and what we can do towards the end for preventing these complications in Asian patients. So when it comes to overall burden of diabetes, we all know that it is very, very high. The current 2023 Lancet Diabetes Endocrinology publication by Mohan's group, based on ICMR data, telling us that we have close to 101 million people living with diabetes in India. But what is much more alarming, the way you said that in Emirates and in Egypt, there is higher conversion from pre-diabetes to type 2 diabetes. So we have even higher number of people living with pre-diabetes. It is as high as 136 million. And if you follow these patients in the natural course of the disease, maybe close to 1/3 of them are likely to get converted to type 2 diabetes over next 5 to 10 years. And unfortunately, diabetes has no boundaries. Gone are the days when it was supposed to be a rich man disease. So even third world countries or Southeast Asians or I am sure even in Middle East, we are actually at a greater risk for developing diabetes, maybe by 1 to 2 decades. And you could notice it that again, this is based on the same study, ICMR data published in 2023, that most of the states, actually the prevalence of diabetes and pre-diabetes is already more than 5%, and they fall into the category of high risk for developing CVD. Not only there is a higher burden in terms of prevalence, because prevalence today is close to 11.4%, and as I told you, pre-diabetes is even higher. There is almost 15.3% of people, those who are living with pre-diabetes in India, as per ICMR 2021 data. WHO very rightly said that more than 50% of the people are not, unfortunately, not even aware of their diabetic status, which leads to health complication if it is not detected timely and not treated in time. That means you are at a greater risk for developing both micro as well as macro as a complication once it comes to undetected or undiagnosed or unmanaged diabetes. So it is not surprising when we say that 4 in 5 people with diabetes, they have HbA1c more than 7%, although we know T to target is, it has to be close to 6.8 or less than 7%. But as per CARS trial 2020 and IDCI trial again in 2020, overall HbA1c across India is very, very high, and more than 80% of patients, they are not under good control because they have HbA1c more than 7%. So let me do a patient who has a typical Indian prototype, who has new onset type 2 diabetes. Clinical presentation is that he's for the first time presenting with diabetes when he's 45-year-old. He's an occasional smoker, newly detected with type 2 diabetes, has hypertension for last 5 years. There are no added symptom, but his BMI is quite high, already falling into the category of obesity. As per Asian criteria, waist circumference is more than 95 centimeters, and patient is already receiving antihypertensive drugs. His workups are HbA1c 8.1%, fasting is 138, which is quite high, but more so is postprandial sugar, which is 212, contributing towards HbA1c. Blood pressure with drugs is under control. His lipids are bad. Total cholesterol is 211. Ideally, it should be less than 150, and so should be LDL less than 100 at least. It is 134. And triglyceride, although in this patients are not very, very high, his urine already is showing microalbuminuria. Creatinine is normal. His EGFR as per CKD EPI is 91 ml, and his LFT is normal. But unfortunately, his exercise test, treadmill test, is positive for coronary artery disease. That means this patient is at a very high risk for developing coronary artery disease. So if we apply QRIS 3 score, which calculates a person's risk of developing a heart attack or stroke over next 10 years, the 10-year risk in this patient is going to be as high as 21.8%. And we know anything more than 20% risk over 10 years is supposed to be a very, very high risk for developing either stroke or maybe coronary artery disease. So there is going to be 7 times higher than healthy Indian male, the risk for developing a stroke or coronary artery disease in this patient. So not only there is a CVD, which is going to be extremely high in this patient, it is going to be a progressive continuum regardless of the clinical event, even if this patient is not symptomatic just now, because we know the subclinical coronary artery disease in asymptomatic South Asian patients at least is very, very high versus the Caucasian patient. So if you see the overall coronary calcium, coronary artery calcium, it is very, very high compared to Caucasian, even if patient is not symptomatic. 30% or more than 30% block in coronary artery is as common as 74% versus Caucasian, it is 59%. And if you talk about a significant coronary artery disease, which is more than 50%, again, it is seen in 41% of patients, those who are absolutely asymptomatic, but they have presence of type 2 diabetes. So may I propose the mechanism of hyperglycemia induced endothelial dysfunction? We know per se it is hyperglycemia along with insulin resistance, which then activates pathways of complication like glucose autooxidation, polyol pathway, protein kinase C activation, or advanced glycation pathway. They together lead on to oxidative stress, lead on to endothelial dysfunction, a decreased nitric oxide production, a decreased prostacyclin, and increased angiotensin 2 expression with increased NF kappa beta, and PIA is on the higher side, which not only induces vasoconstriction, a stage of inflammation, a rampant atherosclerosis, and higher coronary artery disease events in these patients. So it is per se hyperglycemia. We know hyperglycemia has a very linear relationship in terms of propagation of microangiopathy, but even for coronary artery disease, once you have persistent hyperglycemia through these pathways, along with insulin resistance, there is going to be an endothelial dysfunction, a smooth muscle proliferation, an injury to endothelium with a prothrombotic state, which then leads on to inflammation and leads on to a very, very early and advanced atherosclerosis in patient with type 2 diabetes. We all know we belong to a typical phenotype, that is Asian Indian phenotype, which is a thin, fat Indian. That means not only we have a lower BMI as compared to the Caucasian, but we tend to have much higher insulin resistance, much higher CRP levels, increased abdominal obesity or visceral obesity, which typically goes with thin fat Indian, low levels of adiponectin, a typical characteristics dyslipidemia with low triglyceride, low HDL, high triglyceride, and high small dense LDL, which may not be very, very high, and an increased susceptibility to type 2 diabetes and coronary artery disease. And unfortunately, 80% of Indian patients, those who have type 2 diabetes, they belong to this typical thin fat syndrome or Indian phenotype, which increases the risk of not only developing diabetes much earlier as compared to the Caucasian, but also puts them at a much greater risk for developing premature coronary artery disease. And most of the time, this is a rampant coronary artery disease, which could be a triple vessel disease by the time they become symptomatic. Not only that, these patients, they tend to, Asians versus other Caucasians or Americans or European patients, they tend to have higher prevalence of cardiovascular disease. It could be as high as 29.4% or 42% when it comes to coronary artery disease or overall CVD as compared to Caucasian, where it is much lesser. So the overall prevalence of micro and macrovascular disease in these patients, that those are typically South Asians or Indians versus European patient, once you have onset of type 2 diabetes, predisposes them to higher risk for developing microangiopathy, microalbuminuria, retinopathy, advanced CVD, and a greater cardiovascular mortality. Even UKPDS almost 10 years ago, when it sort of said that ethnicity and diabetes related outcomes are very, very important, what Mohammed very rightly said, that when it comes to ethnicity, the population which where we are living, where we are being brought up, is very, very important, because their things may not match with the Western data. So once we compare white Caucasian or Afro-Caribbean population or a African population versus Asian Indians, we are at a much greater risk for all-cause mortality, diabetes-related deaths, or risk for developing myocardial infarction, stroke, PVD, or microvascular disease also. And all these prevalences are much higher p-value-wise as compared to the Caucasian patient. So are Indian diabetics at a greater risk? Let's see our own evidence. Cross-sectional prevalence study, which was a comparison between India, Mauritius, and UK population, again said that we are at a greater risk for developing retinopathy, nephropathy, and in neuropathy also, which is much more common in the southern population, what has been replicated by Dr. Mohan's group in Chennai urban population CUP study, that Indians have considerably higher prevalence of premature coronary artery disease versus European patients also. So overall burden of diabetes related complication, WHO very rightly said that 50% of patients, they are either undiagnosed or they are not even aware of their status, whether they are having hyperglycemia or no. That puts them at a much greater risk or overall cardiovascular risk and mortality, which is much higher in diabetic population as compared to non-diabetic population, and it is much higher in Asian patients versus Caucasian patients. So coronary artery disease in diabetic subjects in Chennai urban population study, it was found that overall prevalence of acute MI was 3 times higher in diabetic patients, those who are living in southern area, as compared to the groups which are non-diabetic or which have only IGT. That means moment there is a worsening of hyperglycemia from a normal glucose tolerant state towards onset of type 2 diabetes, your overall risk for developing MI goes almost 3 times higher. So there is a higher risk for coronary artery disease among not only diabetic patient, but once, because we know hypertension happens to be most common comorbidity with type 2 diabetes. Again, in ICMR 2023 publication, it was close to 50% that almost 50 to 60, 75% of patients, they have hypertension as a comorbidity, which further increases the risk for developing coronary artery disease. But unfortunately, even as per the WHO study, that most of our patients, they are not able to make it to HbA1c less than 7. In fact, only less than 50% patient, they have HbA1c less than 7. They can reach to a target of blood pressure less than 140, 90. They can achieve the target of LDL less than 100 milligram, or even if you talk about all combined targets, HbA1c, blood pressure, and cholesterol, less than 20% of patients they meet the target. In fact, 84% patient they never reach to the target, whether it is alone getting a glycemic control, blood pressure control, or maybe a lipid control. So let's see how a worsening hyperglycemia further adds to coronary artery disease. We know, as I said, not only we are lean thin Indians, we belong to that typical phenotype. We also have a predisposition for developing IUGR over the centuries, and our mean birth weight, what we discuss in our DIPSI meetings also, is close to 2.8 kg versus 3.2, or many Caucasian population having a normal birth weight of the baby as 3.5 kg. So that reduction in birth weight predisposes these offsprings born out of IUGR, either as a result of maybe hyperglycemia in pregnancy or malnutrition. They are at a greater risk for developing adolescent obesity, which increases insulin resistance, coupled with dyslipidemia, hypertension, inflammation, and a hypercoagulal stage that further increases the risk of developing coronary artery disease at a much younger age. So let me propose that there is a common soil hypothesis not only for development of diabetes, but also for development of rampant atherosclerosis through markers of inflammation like C-reactive protein, interleukin 6, TNF alpha, and ICM, which further increase the risk for developing a rampant atherosclerosis. We did this study almost 20 years ago. We looked into flow mediated vasodilation, and we said it could be a marker of endothelial dysfunction very, very early in the course of the disease, not when you are even diabetic. We picked up 5 populations, those who are hospital regularly visiting patient, coronary artery disease, patients with obesity, patient with diabetes and obesity, patients with diabetes and coronary artery disease, and our lean thin ward boys, except the lean thin ward boys who had in normal flow mediated vasodilation. All other population, whether they were simply obese, coronary artery disease, or obese with diabetes, or alone diabetes, they had impaired flow mediated vasodilation. So we said this could be a marker of endothelial dysfunction. We also looked into the prevalence of cardiac autonomic neuropathy in our own patients at our center, and this we presented at ADA 2008. We were surprised that even at new onset, within 1 year of the onset of the disease, when they were negative for peripheral neuropathy, they still had advanced cardiac autonomic neuropathy, as it was picked up by a very, very sensitive equipment, that is Diances, which is a US FDA gadget to pick up cardiac autonomic neuropathy much earlier than in the course of the disease. So as I said, probably there is a missing link which is contributing towards higher postprandial hyperglycemia and higher prevalence of CVD in our diabetic patient. We all know that almost half of the day we are living in a postprandial or post-absorptive phase, except the morning 6 hours when we are truly fasting. Almost close to 16 hours we are living in a postprandial phase. And if we have a poor glycemic control, as is very, very common in our patients, as per this study also published by Dr. Shashank, almost two-thirds of our patients, they never meet the postprandial target of 180, which further increases the risk for developing coronary artery disease in this patient. So you can't say that it is alone the ethnicity, but even the environmental factors, a sort of lack of exercise, a higher carb intake, which contributes toward higher postprandial hyperglycemia, inducing a lot of oxidative stress, endothelial dysfunction, inflammation, and thrombogenesis, which increases the risk of cardiovascular disease in our patient. And every meal, whether it is breakfast, lunch, and dinner, if we exceed sugars more than 160 milligram, close to 180 or 200 milligram, sets in a wave of oxidative stress, inducing fresh endothelial dysfunction in these patients. And today there is a huge evidence over last 30 years that probably that missing link for cardiovascular mortality seems to be either a stage of pre-diabetes, not alone fasting impaired hyperglycemia, or a postprandial hyperglycemia in an established patient, which increases risk of coronary artery disease in these patients. And we know any amount of glycemic control, even if it is simply 1% reduction in HbA1c, might go a long way, primarily to cut down on microangiopathy, but also in regular follow-up, as was seen in UKPDS, will further reduce even the coronary artery disease or myocardial infarction or PVD or stroke risk also. So every effort has to be there to have a multifactorial approach toward management of diabetes, not only to have a glycemic control, but also to address issue of blood pressure, serum lipids in these patients, so as to prevent coronary artery disease in type 2 diabetes patient, at least in Indian or Asian ethnicity, because they are already at a much greater risk for having type 2 diabetes early in the course of the disease, as well as at a much greater risk for CVD once they get type 2 diabetes. I'll stop sharing here and we will go back to all our faculties for some panel discussion. Over to you, Dr. Shalini.
Thank you so much, sir. So I think we've had 3 great lectures, especially on cardiovascular risk, on prevalence of diabetes and pre-diabetes in the expatriates, as well as on the importance of glucose control, weight control, as well as vascular protection when it comes to our patients with type 2 diabetes. So let me just see if we have any questions in the chat box. Stuti, do we have any questions from the delegates?
I have a question for Dr.
Sure, sure, Dr. Meena. Please go ahead.
Dr. Chawla, my question is that do we have a study to suggest how long does it take for the Indian patient to go from IGT to type 2 diabetes? And do you see some people going very quickly? They show us reports 6 months back, they were not even IGT, and suddenly they have become type 2 diabetic with very high sugars. So how do we address, how do you know?
I think if you have look on epidemiological data, overall conversion from IGT to type 2 diabetes is 35 to 50% over 5 to 10 years. That is universally accepted. But I think there are a couple of studies from Dr. Mohan group, and I remember very correctly one publication from Dr. Mohan and Professor Anup Mishra, where they said in the phase of COVID, that conversion from IGT to type 2 diabetes was very, very rapid, because there was a very rapid onset and very high prevalence of new onset of type 2 diabetes immediately in the post COVID-19 phase, which was probably attributable to the fact that most of the patient, they were not doing too much of physical exercise. There was lot of economical and social, you may say, stress on everyone who was living with IGT or pre-diabetes, and many of those patients, they required high doses of steroids for, say, management of their lung manifestation when they had an active COVID-19 disease. But when it comes to comparison versus Caucasian, definitely conversion from, there is a Dr. Mohan's one publication which says that not only we have insulin resistant for our BMI, which is much lesser as compared to the Caucasian, because we tend to be overweight even at 24, because 23 is a normal BMI for us. Even for same amount of insulin resistance, we do have insulopenia also. Our beta cell reserves are much lesser. That probably accounts for faster conversion to type 2 diabetes when once you are exposed to any amount of stress or strain or physical inactivity.
So do we need guidelines which say we check more often? Our
Yeah,
patients, they
that
say
is,
once in 2 years,
yeah,
but if it's
yeah.
normal, we need to check more often.
Yeah. That is why, if you remember, I think it was 2013, Dr. Anup Mishra Group's first publication, which was a consensus on obesity management, where he's for the first time, based on certain studies which are available at that time, and subsequently even in our own RSSGA guideline, we said that if we talk about a moderate degree of exercise, which is 30 minutes, that means 150 minutes of exercise to prevent conversion from NGT to type 2 diabetes. For Caucasian patient, we as Indian require 60 minutes of exercise. That means not only we are resistant, so if we do a regular amount of exercise, which may be lasting for 60 minutes on daily basis, there we said preferably 6 days, while ADA guideline says 30 minutes, 150 minutes over 1 week, that amounts to 5 days a week. For us, it has to be 60 minutes, and even aerobic exercises and resistant exercise at least 2 to 3 times a day, which can prevent conversion from pre-diabetes to type 2 diabetes. So we need to do more. We need to eat less. We need to restrict our carb content, and because carb content is directly going to lead on to postprandial hyperglycemia, which will put more load on beta cells. And we know onset of type 2 diabetes will happen only because of further failure in beta cell or increased apoptosis only. Dr. Shalini, any questions to Professor Mohammed, or
do we have any questions in the chat box?
you may put 1 or 2 questions to each of them.
Question for Professor.
I'm around. I'm here, guys.
Yeah, he's there. Yeah.
So I have a question. Dr. Hasnain, do you have data on type 1 diabetes and Ramadan fasting?
Sure. This is a question out of the agenda, but I'm quite happy to take it.
Out of syllabus, but you are a competent teacher to answer everything.
Sure. Thank you. Go ahead, please, Doctor.
Yes, Dr. Meena, you wanted to ask something to him. Please repeat the question.
Okay, so he's saying this is out of syllabus, but I'm saying that does he recommend fasting for type 1 diabetes patients? And
Sure.
second, yes. And the second question in continuation is, if yes, do you recommend not Ramadan fasting, but intermittent fasting in type 1 diabetes with dual diabetes? Those who have put on weight now and are now insulin resistant after, say, 20 years of type 1 diabetes.
Let me start with the second part. The overlap between Ramadan fasting and intermittent fasting is very strong when it comes to hypoglycemia. Perhaps the intermittent fasting would have the advantage of not having the problems of end of fasting hyperglycemia, which often is the case with any type of religious fasting. Also, intermittent fasting doesn't have the problem of dehydration. So in a way, many people can benefit from intermittent fasting, whether they are type 1 or not. Can a person with type 1 diabetes fast? The question is many can, but about a third opt not to, and about 10 to 20% have problems when they fast. So it's not just the problem of the type of diabetes, but many other personal issues related to the individual. What level of renal function, what type of physical job they do, how frequent and what type of monitoring do they do? Are they, for example, on insulin pump or just on basal bolus? So there are a number of factors which would sway the decision of yes or no. In general terms, of course, the person on full intensive insulin treatment is at a higher level of risk of fasting. But indeed, many of them can do, and just this morning, I was analyzing the data of 2,700 persons with type 1 diabetes. And we have published 2 papers, one of them from 2020, and the other one is a comparison between some of those who fasted from Saudi Arabia versus the rest of the world. In Saudi, many are fasting, but with higher rates of hypoglycemia because of less selection. So if we apply the good selection system, if you put them through the filter and the risk calculator and exclude those with plenty of problems, hypo unawareness, frequent hypos, poor control, renal impairment, physical jobs, then the healthy type 1 diabetes is possibly able to fast. And if they're able to fast Ramadan, they can do the intermittent fasting as well.
Thank you, sir. Professor Amr, I have a question to you.
Sure.
So we said, yes, glucose management is important. Cardiovascular protection is important when it comes to a patient with type 2 diabetes. So where do you put the anti-obesity drugs in this perspective, especially for a type 2 diabetic who's obese, GLP-1s? Now we have dual agonists. Tirzepatide is about to be launched. So how do you see the place of these therapies in a patient with new onset type 2 diabetes who is overweight or obese? Do you think these are the ideal drugs?
Well, the guidelines are very clear and real practice is also very clear. I'm lucky to be working in Dubai where we have tirzepatide and semaglutide injectable therapy. So if you look into the international guidelines, you obviously have to start first by assessing the cardiorenal risk of the individual. Now, once you exclude that, then you're down with the characteristics of the person. How much is weight is an issue versus glycemia is an issue. The beauty of the current GLP-1 receptor agonists or GLP-GIP is that they are very, very powerful on both aspects. Very powerful in the improvement of glycemic control and indeed very powerful in improving weights. Weights, of course. So we are now seeing HbA1cs in some patients that we have never seen before. I'm seeing people going into the 5s, not even 6 or whatever. It's pretty down because the power of the drug in reducing weight as well as improving glycemic control. Unfortunately, obviously the price is pretty expensive. So we are now into the situation of treatment for the rich, which is very different from treatment for the less rich. I wouldn't say the poor, because the cost of these drugs is very inhibitive for cash payers. But if they're obviously is insured or protected with a scheme, then the treatment would be quite feasible.
Mohammed, do you have a hierarchy of drugs? Like when we talk about our own guidelines, RSSDI, Endocrine Society India guideline, we have a wheel approach, ABCDFGH, where we talk of addressing age of the patient, BMI, presence of atherosclerotic cardiovascular disease. Like you have 88 different boxes and ACE also now talking about presence of nephropathy and presence of reduction in ejection fraction. So obviously the best drugs options are GLP-1 receptor agonist or maybe SGLT2 inhibitor. In your Emirates guideline, I think you have shown us and you published in 2020, I think, if I correctly remember, or you revised after 2020 also. Do you have a hierarchy of drugs based on certain evidences?
Sure. We have, since producing the type 2 diabetes guidelines, we have last year produced the cardiometabolic guidelines, which is jointly done with the cardiologists. And what we're recommending, because of the very high risk of the individuals and the very sedentary lifestyle, where classically, normally would detect chest pains or shortness of breath on exertion. But if you're not exerting yourself at all, then you need to screen harder. So we're recommending annual screening that is completely thorough with ECG and even pro-BNP. And of course, the retinal screen, the renal screen, and what have you. And accordingly, we then would put people according to very high, moderate, or low risk. Now, if even they are screen negative, but they have multiple risk factors, including age and duration of diabetes, and the classic cardiovascular risk factors, potentially they could be also on the very high risk category. And these obviously would warrant a treatment with evidence-based drugs, such as GLP-1 or SGLT2 with evidence, and indeed sometimes even combining both.
Professor Amr, would you like to add on to what Dr. Mohammed elaborated on the importance of all these different drugs? But of course, cost is a factor. But when you talk about science, do you think how much optimally have you been able to use these newer drugs for glycemic control, for weight control, and for vascular protection for our patients?
As Professor Hamad mentioned, we have to categorize the patients according to the cardiovascular risk category. This is very high or moderate risk. The weight is very important issue in the management, but the cost is a limiting factor in many countries and in our country. I can't prescribe GLP-1 receptor agonist to all patients. I can prescribe in patient who can bring it or can be sponsored to him to be given from his insurance. So this is a limiting factor for the management. We can substitute this by sodium glucose transporter 2 inhibitors, which are more cheaper in patients with cardiovascular disease, patients with multiple cardiovascular risk factors. Also, we can sometimes I can use obesity drugs or anti-obesity drugs, which are not GLP-1 receptor agonists, as the orlistat, for example, in addition to, for example, the DPOR inhibitor and the metformin or sodium glucose transporter 2 inhibitor and the metformin to decrease the weight, which is a very important issue. The availability and affordability of the drugs is very important issue in the management. We have no tirzepatide in Egypt till now. We have no semaglutide 2.4 in the weight reducing dose. Only the present now is liraglutide for weight reduction or for diabetes. This is the only allowed one.
Yes, thank you so much, sir. So I think we've had a great 3 lectures as part of the first symposium, and now with that I would like to thank our faculties, Dr. Hasnain, Professor Amr, and Dr. Rajiv Chawla for enlightening our delegates on such important topics. With this, now I hand over to Dr. Rajiv Chawla to take forward the second symposium, along with his co-chair, Professor Abdur Khalik Hamid.
Yeah, thank you. I think it was a wonderful starting session today. And we go to the second symposium. May I request Professor Hashim Mag Elnidin to be the co-chair. He's a professor of internal medicine at Cairo University, member of ASD, member of endocrinology, and a senior consultant at Egypt itself. Do we have Professor Hashim?
Yes.
Is
yes.
there? Okay.
Yes.
Sir,
Good
over
afternoon,
to you.
everyone.
Yeah. Thanks, sir.
Good evening,
Thanks
sir.
a lot.
Welcome.
Thanks for being with us. We welcome you to this joint symposium by CMRE ASD. You are a very active member and official of ASD. So I think it's your privilege to start the first session, and you may invite Professor Gamila.
Thanks, Doctor. I'd like first to thank the organizing committee to give me this chance in sharing this very important international symposium, and I want to have a good discussion, inshallah. Now we'll start our session with Dr. Jamila Nas. She is a professor of cardiology, Suez Canal University in Egypt. She will talk about organ protection in diabetes. I think this is the ultimate goal, yes, of all of us, to protect the organs from diabetes. And so please, Dr. Jamila, go on.
Hello, you hear me?
Yeah.
You hear me?
Over to you, madam.
Yes, madam.
No, it's nice meeting you, and I'm very honored to share this meeting. And as you know, I have had a lot of data which I enjoyed very much. Thank you. Thanks also goes to Professor Ines Chaltout, my dear professor, and I thank her very much. However, it's really a very difficult talk, because when we are talking about organ transplant, organ protection, this is very important. This is a very horrible figure. We're all really afraid of. This is the atherosclerosis pipeline, and this is really very alarming figure, and we are all afraid of. And we don't like it at all, of course, as we all know. So my presentation about organ protection in diabetes, and really, what about the proportion of countries spending of at least 5% of the GDP on health? This is to start with. The high-income countries, of course, so we are talking about the cost of health. And when we are talking about costs, around 97% of in the high-income countries, they spend at 5% of the GDP on health. But on the other side, there are countries who are not able to do this high expenditure. Maybe in sub-Saharan Africa, it's 45%, maybe in Latin America, Caribbean 71, North Africa, Middle East around 50%. So I think this is very important, and maybe we should comment on this very importantly. What about diabetes in Africa? When we are talking about diabetes in Africa, actually it's estimated 24 million people in Africa having diabetes. This is a very important, in the year 2021, pre-diabetes increased by 129%. And it's going to increase by the year 2045, which is very, 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 very high. I think we are going to anticipate a big problem in Africa the coming years, but having a lot of people are being diabetic, pre-diabetic. Africa had the second lowest diabetes-related expenditure, around accounting only for 1% of these related diabetes health-related expenditure. Again, more than half, 54% of people living in Africa region are undiagnosed. Only 36% on countries in Egyptian region have essential medicine for chronic diseases in public health hospitals. And so this is very important. What about the risk? Africa bears the brunt of cardiovascular burden and has, unfortunately, the highest risk of dying from non-communicable diseases. In Egypt, actually, we do have 86% of the Egyptian die from chronic diseases. And we can see that actually Egyptians, 46% of Egyptians die from heart disease. There's currently an epidemiologic transition on the continent where non-communicable disease is projected to outlet, and this is coming to prevail. There's unchecked increase in cardiovascular risk factors contributed to the growing burden of many risk factors like cardiomyopathies, atherosclerotic diseases, cardiovascular disease, hypertension. The DALYs, or the highest age-adjusted disability, really, it's very high. It's due to hypertension. So, or heart failure, this is the end of many heart disease. It's really a really important problem because we do have ischemic heart diseases coming a significant contributor to this impact. We have challenges because diabetes is a silent killer. We have limited diabetes knowledge. We have limited diabetes testing. The cost, as you have mentioned in the last discussion about the cost and access to medication, actually is very really it's different in many people. Many people cannot afford these in the long term. So we have this is very important, and 54% of people living in Africa have diabetes. This is very important. Type 2 diabetes has been growing in sub-Saharan Africa along with the epidemiologic transition. And of course, there are some importance. Infections are a major contributing cause of morbidity. However, they are not the main cause of disability. This is an Egyptian screening for diabetes published in the Clinical Diabetes, and they're looking for the diabetes and the cardiovascular risk among Egyptian population, in particularly, and looking for the IDF criteria for diagnosis of the metabolic syndrome. And we found that looking for the around 20% of Egyptians having the metabolic syndrome, which is it is a big high percentage of the Egyptians, and it's very important. I just came a few days ago from the European Society of Cardiology meeting, which was held in London couple of days ago, and actually they have focused upon the prevention and said that never too soon to start cardiovascular prevention. The earlier the better, and this is really very important. This is the ESC, European Society of Cardiology Congress in London in the 30 August to September. And it's really have focused upon prevention. And this is very important. And really on Brunwald Corner, this is a of course, very famous cardiologist, one of the ever famous cardiologists all over the world, had a very important stress upon the climate change. And we should consider this, because climate change is really a growing threat, excessive heat. This will be very important. It's for heart and of course for the diabetics, who are having complications with heart disease and other disease. So we are seeing a radically interesting and promising changes in the treatment of patients with diabetes type 2, which favorably modify the prognosis related to fundamentally nephro-cardiorenal outcomes. So this is really very important. Since no more than 2 decades ago, the pharmacological armamentarium for the treatment of people with diabetes has basically consisted of use of big one-eyed sulfonylurea, insulin sensitizers, insulins, but a great amount of information has been accumulated through the results of new molecules, for example, such as sodium glucose cotransporter type 2, SGL2 inhibitors, based on the robust data arising from the experiences of numerous studies, both clinical and experimental, as well as the glucagon-like peptide 1 receptor agonist that has clearly shown multi-system benefit that improve the function of target organs and delay the onset of complications that ultimately impact the quality of life and nephrocardiovascular outcomes. So I have just to say a very important thing. It is from a glycocentric approach to prevention of multi-organ damage in type 2 diabetes. And really, this is very nice title. I enjoyed very much. Type 2 diabetes, of course, as we all know, having a lot of risk factors, whereas there is dyslipidemia, the metabolic syndrome, the ethnicity, the polycystic ovary syndrome, dietary factor, sedentary life, obesity, age, family history, genetic factors, and many others. Diabetes 2024. Actually, as we know, that there was a little bit change in the hyperglycemia. It's a chronic metabolic syndrome affecting around more than, I think, 530 million people around worldwide. But it's characterized by chronic high blood glucose due to deficiency in insulin production, peripheral body resistance to it, or both, the phenotype expression of the genetic defects and diabetogenic genes, conditions, alternations in insulin secretion, while there is the peripheral insulin resistance is a consequence of the interaction of environmental risk factors for the type of diet, for the sedentary life, etc. So this is very important. And the diabetes has changed over time from just a unique approach collectively from insulin resistance in muscle and liver and beta cell failure referred to as this to just an interaction of several phenomena. And this is the phenomena, the octet, and this octet refers to the interaction of different pathways and organs related maybe the increased glucagon secretion, maybe the increased gluconeogenesis, the increased lipolysis, insulin resistance, decreased incretin effect, decreased peripheral glucose uptake, increased renal glucose reabsorption, alteration of neurotransmitters. All these leads to this octet, or this is very important. We have complications, and we know there are many pathways leading to complications: hyperglycemia, glucose fluctuations. Now we are talking about glucose variability, and of course, variability affecting the complications of the patient's insulin resistance, all lead to endothelial dysfunction and many other complications. Of course, the major complications are coming from major complications, macrovascular, coronary heart disease. Of course, it's increasing and it's very important. We do have the heart failure is high, and actually we have witnessed that these patients having the diabetic myocardium through imaging studies have showed that the left ventricular concentric remodeling per se, even without other comorbid conditions. So it's possibly attributed to impaired myocardial energetics and reduced systolic strain. So myocardial hypertrophy is attributable to hyperinsulinemia, myocardial triglyceride deposition, increased extracellular volume, which may promote collagen deposition and fibrosis. This is very important. Cerebrovascular disease, on the other hand, is highly susceptible in suffering cerebral diabetics, is usually very prone to have a cerebrovascular event, and they are 12 times more likely to be hospitalized due to these events. Peripheral vascular disease as well is a common complication. And we can see that the patients with it's a predictive factor for generalized arterial dysfunction. And of course, this is very important. Unfortunately, the peripheral vascular disease is a disorder that occurs asymptomatic in many patients. We have microvascular complications, retinopathy. We have the most common cause of blindness worldwide is diabetic retinopathy, and it appears to approximately affect around quarter of the diabetic population. This is very important. Nephropathy as well, impaired kidney functions in diabetic patients. It's approximately affect 25% of people with diabetes. Again, is very important. So current medications, if we are talking about current medications, we have, despite the successful generation of major differences in glycemic control, and we had a lot of studies, UQPDA study, Accord study, the VADIT study, different ways of studies. But recently we are talking about the SGL2, which we are saying that's a game changer. And this was really very important because really it has a sodium cotransporter known as gliflozins or flozins are relatively new glucose lowering drugs that they include IMPA, DAPA, CANA, ERTU, and they are used as for treatment of type 2 diabetes. By inhibiting the SGL2 expressed in the proximal convoluted tubule of the nephron, which is really responsible for 90% of glucose reabsorption, these drugs favor glycosuria and hence lower glycemia level. Although they are believed to cause smaller glycated hemoglobin reductions between 0.5 to 0.7 than less than other antidiabetics, but they offer multi-organic benefits addressed, which is really very important, neuro, cardio, nephro, and this is very important. This is really an important sodium glucose cotransporter inhibitors, and it's published days ago, the circulation, and showed that they reduce the risk of MACE, major complications in the broad range of the patients, irrespective of the cause of atherosclerosis. And this is really very important and may help inform selection for this patient with SGL2 inhibitors. Again, the risk of diabetic retinopathy, when you can choose whether to give sodium glucose SGL2 and glucagon like peptide 1 receptor agonist. They found that the patient having SGL2 inhibitors had a lower risk of proliferative diabetic nephropathy, and this is really very important, maybe less complications in these type of patients. What about the IMPA? And this is a really very important neuroprotective effects. In empagliflozin per se, as we know, the very common molecules for SGL2 inhibitors, maybe the IMPA and DAPA, and maybe the IMPA, it has a neuroprotective effects. Why? Because it's a lipid soluble drugs. They can cross the brain-blood barrier. They can exert interest neuroprotective effects. Maybe when appropriate brain concentrations are reached around 0.5 micrometer, this medication works as an acetylcholinesterase inhibitor. When activity this is decreased, the acetylcholine M1 receptors face an important increment and thus favor a functional cognitive improvement. This is really a very important fact. So patients type 2 diabetes tend to have low brain-derived neurotrophic factor levels, this becomes relevant when realizing that it plays a crucial role in neuronal growth and plasticity. So hence cognitive impairment is propagated, and not to mention that it's been associated with inflammation. So this is one of the a positive effect of organ in the neuroprotective effects. What about the cardioprotective effects of this molecule? It has been associated among randomized trials to lower hospitalization, MI, non-fatal strokes, and that is, although these may sound like greater effects, there are other significant ones, like decrease in the post-systolic diastolic blood pressure, which is really very important. And as a cardiologist, we see that the decrease in it hasn't compensatory higher heart rates. This means a lot to the cardiologist, because we are not very fascinated with the high heart rate. We always feel very comfortable with lower heart rate for the cardiac patients. So there is a reduction in weight with circumference, uric acid levels mainly. There is also the heart failure is recognized as an important diabetic comorbidity, so it has a diuretic effect. So it can be said that its main effect focuses on reducing the plasma volume, leading to increased hematocrit and expected blood pressure response in 12 weeks duration. So this is alleviating the work of the heart. Again, the nephro, so I've the neuro and the protective effect on the heart, and then coming to the nephroprotective effects. They, of course, we know that diabetes type 2 have susceptible to developing microvascular complications, such as kidney disease, affects around 35% of them and magnifies mortality rates. This reason is sufficient to look for the innovative therapies like SGLT2 use. In several trials, it's been demonstrated that have a renal protective effects, even though the underlying mechanism is not well evidenced, as we have stated for the neuro and the heart. Nevertheless, it's believed to be a summation of the association with blood pressure and body mass reduction, diuresis, activation of tubuloglomerular feedback. What about DAPA? As we know that, of course, DAPA, on the other hand, is an important, another molecule, which is really very important on the other hand. What about the difference about neuroprotective effects? DAPA has no significant improvement in cognitive domains, nor in impaired brain activation compared to other drugs. However, the rat model suggests that quite impressive effects. So it's they said there's some improvement. However, there is demonstrated both antioxidant and anti-apoptotic properties by alleviating memory. It's little bit differences in both molecules for the IMPA and DAPA. What about the cardiology, the cardioprotective effects? Actually, it's harbor considerable. Of course, diabetics have a long, harbor considerable risk factors. So they are more susceptible to have atherosclerotic cardiovascular disease and its derivatives. So we know that, you know, the outcomes is really very important according to the DECLARE TIMI 58 clinical trials proven to diminish. So it's improved these risk factors. And this as a fact sustained by evident lowering of hospitalization for heart failure patients. What about nephroprotective effects? Worrisome renal outcome in type 2 diabetes if they have not already progressed into kidney disease. Therefore, the fact that SGLT2 DAPA has been studied and tested in clinical trials represent a scenario leading to new windows of opportunity, and this is really very important. And the trials as DAPA, CKD, DECLARE TIMI 58 found that when administering DAPA really versus placebo, there was a lowering of the decline of the estimated GFR, estimated glomerular filtration rate, meaning a reduction in the progression of the lung of the kidney disease. Yes, this is what about the other gliflozins? Can ERT also have relevant medications belonging to the SGLT2 class, as could be expected in Egypt? Actually, the practice is not with more IMPA and DAPA, and it's provided to a lot of patients. As could be expected, they both have other gliflozins, they demonstrated expected efficacy in lowering hyperglycemia and exerting favorable cardiorenal effects in their principal clinical trials, Credence and Vertis CV, respectively. Let us shift again to the other, the GLP-1 receptor agonists, though they are a little bit very expensive in comparison with the SGL2 inhibitors, and they are of less common practice, and it's an incretin hormone released from intestinal cells of the distal ileum. Actually, this is another, so it's really another way of action, and as we can see that it's prostaglandinally secreted and binds to a 7 transmembrane G protein coupled receptor to activate signaling cascades, leading to beneficial downstream effects that include increased insulin secretion in a glucose-dependent manner, somatostatin secretion, lipolysis, decreased glucagon secretion, decreased gastric emptying, satiety, which leads to promotion of weight loss. As they are usually use it as an anti-obesity drugs, and it has a common practice. One of them, of course, as this is really very important. Dulaglutide and neuroprotective effects. It's just demonstrated really, and that dulaglutide possesses protective effects on the pathogenesis of experimental autoimmune encephalomyelitis, which is established animal model to study human multiple sclerosis, which may prove to have in the long term it have another indication. What about dulaglutide and the cardioprotection and the cardioprotective effect? The REWIND trial carried out in 24 countries to assess the cardioprotective effects with dulaglutide in patients with cardiovascular risk factors who were under hyperglycemic regimen, suggested that dulaglutide reduced the cardiovascular events. It also reduced weight. Its main impact on weight, the LDL, the cholesterol, blood pressure, suggested as the mechanism by which dulaglutide exerts cardioprotective effects. What about nephroprotective effects? In the REWIND trial, again, renal outcome were collected as a part of the secondary microvascular outcomes. It showed that it reduced all 3 components of composite renal outcomes and the development of new macroalbuminuria, a sustained more than 30% decline in the EGFR, chronic renal replacement therapy, having a robust effect on the development of microalbuminuria. So it showed that this REWIND study have showed that the dulaglutide reduced the progression of kidney disease and preserved renal function by reducing the glycated hemoglobin and systolic blood pressure. Actually, and there are other data saying that the GLP-1 receptor agonists are agents that directly affect the kidney by reducing inflammation and oxidative stress, which may have confer additional benefits. What about semaglutide? Semaglutide, of course, as we all know, it's although GLP-1 receptors are expressed in some brain regions, there are some reports suggesting that semaglutide does not cross the blood-brain barrier. However, it may have access to GLP-1 receptors through leaks in the blood-brain barrier or have an entry into additional regions of the brain. They could not enter the blood-brain. Besides, semaglutide improves factors in the progression of metabolic and neurodegenerative diseases. There have been studies that shown that neuroprotective efficacy of semaglutide in the rat model and in human neuroblastoma, decreasing the inflammation and apoptosis. So it can be safely administered, even though we are not sure that it has a beneficial effect. What about, and especially in the geriatric patients with renal, hepatic, and cardiovascular disorders? What about the cardioprotective effect? Semaglutide, the long-acting GLP analog with an extended half-life, approximately 1 week, has been shown to inhibit exercise induced oxidative exercise, induced myocardial oxidative stress and inflammation. It has a cardioprotection by activating many pathways and decreasing the inflammation, which really leads to an increase in the myocardial, which may have some favorable effects. Both the study, there was a Sustain 6 and Pioneer 6 demonstrated that semaglutide reduces 24% cardiovascular adverse effects. Semaglutide-treated patients had a lower risk of nephropathy, but a higher risk of diabetic retinopathy complications. So we can see, we can find that semaglutide may have a higher risk of diabetic retinopathies, vitreous hemorrhage, blindness, need for treatment with intravitreal agents, photocoagulation, in comparison with those receiving a placebo. So really, we have to need to many more trials to uncover this problem with the drug. And this drug may have shown sustained weight loss and the reduction in systolic blood pressure versus placebo in 2 years. And this is, of course, it's the first semaglutide is the first long-acting GLP-1 receptor agonist to be approved in the United Food and Drug Administration for obesity management. What about the nephroprotective effects? Recent evidence support that GLP-1 receptor agonist improved the cardiovascular renal outcomes in diabetic patients by promoting weight loss, blood pressure, glycemic control, semaglutide to improve the cardiorenal outcome in patients with type 2 diabetes. So the antihypertensive action of this drug may be secondary to the diuretic, natriuretic effect, and there is a speculation that the nephroprotective activity of semaglutide could be linked to the improvement in renal hemodynamics. And GLP-1, as we all know, receptors in the kidney are reported to be in the vascular smooth cell and muscle cell as well. This is really very important. And we have other dual triple agonists, several trials are reported that there is other GLP-1 analogs. I don't want to be boring and talk about this, but we have another a new lexinetide has a protective effect of behavioral and neurological functions. We have a lot of agonists, so I don't think we do. Again, very important that the tirzepatide, of course, again, it provided some important protective effect in some diabetic patients. So with all this information, I have to say, and in view of this promising panorama with these new molecules whose outcome favor a better prognosis regarding control of the glucose, weight reduction, microvascular, macrovascular complications, it's really important to consider a personalized holistic therapy for each patient to improve their quality of life and to reduce their morbidity and mortality. Although we have, as we all know, a tremendous advancement in diagnostic therapeutic tools in cardiology, physician experience, pharmacotherapy, patient awareness, we still have the cardiology as the heart disease number one cause of death all over the world. And we have a continent which is disappearing every year, and the whole world around 19 million dying from heart disease. Of course, lifestyle intervention definitely they decrease the complications and they promote the organ and the function. Obesity is a very important item, and in the ESC last EC has stressed upon this is a funny way as having subway ticket machine and accepts squats. So this is a good way of using technology in some patients. This is the good way. This is a very bad use of technology and leading to pizza consumption, a lot of bad dietary habits leading to an important effect. Anti-obesity medications that impact the pre-diabetes and diabetes, and I have mentioned, of course, that the maybe semaglutide, one of these very important items. Still, the global in women still it's a different story. And the ESC found stated that the women are still undiagnosed. We have a lot of and untreated, and definitely we have 275 million women diagnosed with cardiovascular disease. That is attributable to heart disease. Around 35%, 9 million die from cardiovascular disease. A concept of health. This is a free survival, the longevity, and we have to look not for the primary, secondary, tertiary, quaternary prevention, but we had to look for primordial prevention, predisposition of disease, a neutral environment, epigenetic screening intervention, and luckily we can say we can prevent 80% of heart disease by having self take care of ourselves, and before the professional care, 80%. And I'm sorry, so this is the iceberg. We have to establish a culture of health living, and this is the wealth of health, as Rolf Waldo Emerson have said. That's the first wealth is health, and we do have in Egypt the universal health coverage, which is a quality improvement is going on, and this is a very way of doing taking care of the population health. And this is the summary and conclusion: more personalized diabetes prevention in the guidelines in a state of one size fits all. This is also the introduction of a stepwise approach to intensify preventive measures, and African countries required investment and resources to manage the burden, increasing burden of non-communicable diseases, and diabetes should be integrated in the existing primary health care services to cover cost long-term in treatment and diagnosis. And I love this last slide, and states it's a slide of prevention, and this was stated by the European Society of Cardiology and said 035140530. People who stay healthy tend to have certain characteristics. 0 for no tobacco, 3 walk 3 kilometers daily or 30 minutes any moderate activity, take 5 portions of fruits and vegetables a day, keep your blood pressure ample at around systolic less than 140, of course, as well as the diastolic. 3 keep your lipids at ample amount, and 0 avoidance of overweight and diabetes. Thank you very much, and greetings from Egypt, and I do have the honor to share in this honorable meeting. And again, thank you all, and very special thanks to my dear Professor Ines Shaltut, who we admire so much in Egypt, and we always call her the Lady of Diabetes in Egypt. Thank you very much.
Professor Gamila. Thanks a lot for a wonderful session. We'll request you to stay back for the panel discussion towards the end. We go to the second session, that is by Dr. Shalini Jaggi. She's going to talk about fit fat. Is it a myth or a reality? Whether it's a concept of fit, whether while being fat you can be still fit, and she's a very strong advocate for that. That with fat also you can have a wonderful fitness, and you can have actually a reduced cardiovascular mortality. She is a consultant and director, Life Care Diabetes Center, New Delhi, fellow Royal College of Physicians of London, Edinburgh, Glasgow, fellow American College of Endocrinology, governing council member, DIPSI, chair-elect RSSGA Delhi chapter, and such.
We can start.
Okay, Ji, over to you.
So thank you so much. And as we are a little behind time, so I'll try to be very crisp and quick. Just a minute. So I hope my slides are visible.
Yes.
Yeah. Okay. So friends, I think all of us think that sometimes, being fat but fit may still be safe. And this is where I'm going to do some myth busting on telling you how, even if you are fit, being fat may not really be the answer. So obesity, as we all know, is defined as an abnormal or excessive fat accumulation that impairs health. And why we've been talking about overweight and obesity all along is because of its association with all these different metabolic abnormalities that we know, right? From glucose intolerance, type 2 diabetes, dyslipidemia, NAFLD, hypertension, and increased inflammatory state. So essentially, it is a leading preventable cause of cardiometabolic diseases and mortality, and therefore an increasing prevalence of obesity is something that is very, very important. Now, when it comes to the complications of obesity, there are many: mechanical, psychological, sociological, economic, but when it comes to the medical complications, you can see all organ systems are affected. Most importantly, NAFLD, pulmonary disease, gallbladder disease, you have gynecological abnormalities in women, increased incidence of cancers, osteoarthritis, strokes, cataracts, and coronary heart disease because of the plethora of all these metabolic problems like diabetes, dyslipidemia, and hypertension. So moral of the story is obesity is associated with a significantly increased risk of all these different metabolic problems and increased cardiovascular risk and mortality. So does it mean that fat is not fit? Well, if you look at the different phenotypes based on the BMI and the metabolic status, you can divide them into 4 different categories. So one extreme is people who have a normal weight and are metabolically healthy, no metabolic derangements. And the other spectrum is people who are overweight, obese, and have metabolic dysglycemia, dyshealth, metabolic ill health. So these are people who are obese and have a metabolic profile which actually talks of hyperinsulinemia, diabetes, sarcopenia, dyslipidemia, inflammation, high cardiovascular risk, and high cancer risk. And then, of course, you will have a category of people who may be obese, but still metabolically healthy. And then people who may still be normal weight, but their metabolic health is still challenged. So in simple terms, metabolically healthy, obese, or MHO is a subset of population who have a BMI which is more than their ethnic standard, which could be more than 30 in Caucasians or more than 25 in Asian Indians, which is the typical definition of obesity. But these are people who seem to be living normal, healthy lives in comparison to a majority of the obese people who have metabolic ill health. Now, these are individuals in whom cardiometabolic risk factors are largely absent. So therefore, these individuals are implied to have good metabolic health, which means no cardiometabolic complications. And in contrast to these, you have the metabolic unhealthy obese, where the excess risk of adverse cardiometabolic and CVD outcomes is present. So conventionally, what is metabolic health? Metabolic health is defined using either a cluster of indicators of metabolic syndrome, which means dyslipidemia, blood pressure, glucose, abdominal obesity, or insulin resistance. And therefore, there are heterogeneous definitions for this term, but essential parameters, there's no standardization, but essentially it talks of people whose BMIs are on the upper side, which means more than 30 or more than 25 based on the ethnicity, but their metabolic profile is perfectly normal. That means serum triglycerides are less than 150, HDL is more than 40 for men or more than 50 for women, systolic BP and diastolic BP are less than 130 by 85, fasting glucose is less than 100. And these are people who are not on any kind of treatment for diabetes, hypertension, dyslipidemia, and have no cardiovascular disease manifestation per se. So the prevalence of metabolic healthy obesity varies in different cohorts, suffice it to say between 12 to 35%. So what is important is to understand what causes this metabolic state in obesity. This is where we need to understand the role of adipocytes in metabolic regulation. First, we know that adipocytes store triglycerides, which are synthesized from fatty acids after food digestion. And then secondly, during fasting, triglycerides, they undergo lipolysis, produce free fatty acids, and these are then released into peripheral tissues to be used as energy fuel through beta oxidation by peripheral cells. Now, the liporegulatory function of adipocytes is controlled by adipocytes themselves by secretion of adipokines such as adiponectin and leptin, which enhance the beta oxidation of free fatty acids in mitochondria or peripheral cells. So a dysfunction of adipocytes, which means either the lipid storage becomes dysfunctional or the liporegulation becomes dysfunctional. This will change the dynamics between free fatty acid release and their oxidation in peripheral tissues. Now, what we need to understand is the non-adipose tissue cells have a very limited capacity of storing free fatty acids in the form of triglycerides. So therefore, whenever the free fatty acids arrive in peripheral tissues through beta oxidation, they need to be immediately oxidized. Now, if this capacity is exceeded, the bioactive lipid metabolites will remain accumulating in the cells, causing lipotoxicity and causing insulin resistance. So therefore, what we need to understand is whenever there is excess nutrient intake, the storage capacity of adipose tissue will depend on how many normally functioning adipocytes are present, the number of these cells,
and the capacity of these adipocytes to expand through hyperplasia to accommodate this excess nutrient intake. So largely the excess energy is stored as triglyceride in the white adipose tissue. Triglycerides are released when needed, such as during starvation or during exercise. So the white adipose tissue can store more triglycerides by increasing the number or the size of adipocytes. Now, what we need to understand is the subcutaneous adipose tissue expandability is limited for every individual depending on various genetic and environmental factors. So what happens when a person gets obese? These adipocytes, they become excessively large in the extreme phenomena called supersizing of adipocytes. So these are overwhelmed with energy surplus, which far exceeds the normal storage capacity. And thereby, there is an overflow of lipids into peripheral tissues. Now, if adipose tissue cannot exert its normal storage and liporegulatory function, this will lead to metabolic dysregulation with resulting insulin resistance and cardiometabolic consequences. So what I'm trying to tell you is that when there is a consumption of excess calories, these are stored as triglycerides. Now, if the adipocytes become very large, this leads to the triggering of all these different inflammatory markers, which increase fatty acid release, leading to a background insulin resistance. And therefore, this is what leads to an unhealthy obesity. On the other hand, if excess calories are stored as triglycerides, but there is no increase in size, the number of adipocytes increases, there is no inflammation, and this is what is termed as metabolic healthy obesity. So basically, it is the increase in size leading to inflammation and inflammatory cytokines, which predispose to insulin resistance, leading to a dysregulation of the metabolic profile, and therefore what we call metabolic unhealthy obese. So in simple terms, no insulin resistance, the person remains metabolically healthy obese, whereas if there is insulin resistance, the person becomes metabolically unhealthy obese. So why are these different effects happening in obesity when it comes to metabolic health? This is where we need to understand that the most important cause for development of insulin resistance is obesity. However, the critical determinant of insulin sensitivity is not the degree of obesity, not the BMI, but the distribution of fat partitioning that happens in an individual. So when a person is viscerally obese, there's visceral obesity under conditions of excess nutritional intake, adipocytes will become hypertrophic and dysfunctional, leading to lipid deposits in peripheral tissues. This is what applies to metabolic syndrome or different insulin resistant syndromes. So what happens if there is excess spillover of lipid metabolites into the liver? There's hepatic steatosis leading to hepatic insulin resistance and thereby an increase in hepatic production of glucose and triglycerides. If these lipids accumulate, spill over into the muscle cells, there's muscle insulin resistance, and similarly, ectopic lipid in the pancreatic islets may induce beta cell dysfunction and apoptosis, which we know leads to insulin resistance, eventually predisposing to type 2 diabetes. Therefore, there are three distinct mechanisms that have been proposed to link obesity to insulin resistance, which predisposes to diabetes. A, increased production of adipokines and cytokines. Second is the ectopic fat deposition, especially in the muscle, in the liver, and all the dysmetabolic sequelae that I talked of, and mitochondrial dysfunction, which eventually can be a very important underlying defect which links obesity to diabetes, thereby decreasing insulin sensitivity and compromising beta cell function. So in simple terms, when there is adipocyte tissue hyperplasia, there's normal angiogenesis, normal adipogenesis, small insulin sensitive adipocytes. So it's just an increase in the number of adipocytes, which remain small but are insulin sensitive, and therefore it is essentially the building up of the subcutaneous fat stores that are occurring. Therefore, these are the individuals we call metabolically healthy obese. On the other hand, if there is hypertrophy of the adipocyte, there is inadequate vascularization leading to hypoxia, apoptosis, adipose tissue stress. So there's necrosis and fibrosis resulting in ectopic fat stores, especially in the liver, in the abdominal viscera, in the pancreas, in the skeletal muscle. And all this creates a diabetogenic milieu, an atherogenic milieu with pro-inflammatory signals. And these are the metabolic unhealthy obese people. So now the missing link is not all obese individuals display a clustering of metabolic and cardiovascular risk factors. And likewise, not all lean individuals will have a healthy metabolic and disease-free profile. because we know that there are lean individuals who have metabolic profiles which are as unhealthy as that of the obese. So therefore, when I talked of the obesity phenotypes, you have the metabolically unhealthy obese, metabolically healthy obese, and then you have the metabolically obese normal weight individuals whose weight is normal, but they are still having a metabolic profile which mimics that of an obese person. Now, when it comes to an MHO, now these are the transabdominal MRI scans from two females with identical age, identical BMI. And as you can see, the yellow highlighted area is the visceral fat depot. So these are women where clearly it shows that in a woman who is metabolically unhealthy, there is much higher amount of visceral fat. So for her, the high liver fat content and predominantly abdominal, especially the visceral adiposity, leads to metabolic unhealthy phenotype. So there's lower amount of leg fat, there's lower cardiorespiratory fitness, there's high liver fat content. Whereas in the metabolically healthy phenotype, you will see better insulin sensitivity, you will see better insulin secretion, cardiorespiratory fitness, and lower body subcutaneous fat mass, both or all of them associated with the MHO phenotype. So what are the determinants of metabolic health? And we had previous speakers talk about this: lifestyle, genetic factors, the amount of visceral adipose tissue, and the ectopic fat deposition and inflammation. So we know that physical activity keeps away the person's cardiometabolic risk. All the dangerous effects of obesity can sometimes be circumvented by increasing physical activity. And an example is the sumo wrestlers, who are huge but very healthy. Blood profiles look great, excellent glucose tolerance. But what happens? The moment they retire, the physical activity stops. And this is almost a death sentence, because there's data which shows that usually they will die within a year of retiring and stopping all this excess physical activity. So what causes protection in these metabolic healthy individuals? Well, this is a study that compares the cardiovascular risk, the cerebrovascular disease, heart failure, PAD, CV events, diabetes, all-cause and cardiovascular event mortality between the metabolically healthy lean individuals, as you can see in black here, versus the metabolically healthy obese and the metabolically unhealthy obese. Now, see, metabolic unhealthy obese, of course, all these risks are very high. In comparison to that, the metabolic healthy obese people have lower risks for all these events. But still, what you need to actually see closely is if you compare these metabolic healthy obese people with the metabolically healthy lean people, they are still at an increased risk. So therefore, friends, individuals with MHO are at a higher risk for atherosclerotic cardiovascular disease, cerebrovascular disease, heart failure, CV events, diabetes, all-cause mortality, when you compare them to the metabolically healthy lean individuals. So maybe being fat is not really good, not really fit. Now, this is a study in weight discordant monozygotic twins. So these were 16 discordant identical twins examined for all these parameters of metabolic health. As you can see, 8 pairs of twins, the obese twin was metabolically healthy, as his lean co-twin. But in the other 8 pairs, the obese twin had a poorer metabolic profile, poorer lipid profile, higher liver fat, increased insulin resistance, higher blood pressure. And what was seen was in these obese co-twins, it was essentially the chronic inflammation, the insulin resistance, which was predisposing them to complications and disease. So therefore, clearly, it was seen that only those individuals who, along with obesity, developed subacute adipose tissue dysfunction, these were the individuals who went on to have fatty livers and hallmarks of metabolic syndrome over a 12-year follow-up. So friends, the important question is, does a metabolic healthy obese individual stay healthy for the rest of his life? Or is it just a stage in transition from metabolic health to a metabolic unhealth? So is metabolic healthy obesity a myth or a fact? Well, this is an excellent concept called the fit fat concept, which says that high levels of cardiovascular fitness may attenuate or potentially eliminate the risks that are associated with several metabolic and cardiovascular disease outcomes independent of the BMI, even among individuals who are obese. So this is a database. This is a study of about 4,675 adults from US, the NAINS database, wherein they looked at people who were obese in terms of the BMI category, and they looked at what was their amount of exercise and cardiovascular fitness. And clearly, this study went on to show that individuals who had a high amount of exercise, who had cardiorespiratory fitness, these were considered fit but fat, and that obesity was independently associated with reduced cardiovascular fitness in individuals who were not exercising. Therefore, if obese adults can indulge in physical activity, which is sufficient to improve their level of cardiovascular fitness, it may help them to reduce not only their body weight, but also the excess health burden in this population. So this is again another study, the MESA study, which looked at an association of obesity and metabolic syndrome with CVD and mortality on a follow-up of 12.2 years. And clearly it showed that metabolic healthy obesity was not significantly associated with incident CVD. But when they were followed up, the unstable metabolic healthy obese, one half of these people eventually went on to develop metabolic syndrome. And this was the group that had an increased odds of CVD. So therefore, it is seen that eventually over time, the metabolic healthy obese may eventually go on to become metabolic unhealthy obese, and that is where their risk for cardiovascular disease goes up. So MHO is not stable or a reliable indicator of future CV risk. Therefore, it is important that even if the individual is in the MHO category today, we talk about weight loss and lifestyle management to attenuate their CVD risk. So individuals can be found at any age. With increasing age, we know that metabolic healthy obesity reduces and patient becomes more and more metabolically unhealthy obese. Almost 30% women transition in the postmenopausal period from MHO to MUO, that means the unhealthy obesity. And all these studies have gone on to say that. So clearly, friends, all these studies, the EPIC CVD study, all these follow-up studies, this is a 90,000 plus women followed up in the nurses health study, clearly again looking at their metabolic health and change over time. So these were women who were initially metabolically healthy obese, but then when they were followed up, eventually it was seen that CVD risk of these women increased in comparison to women who had normal weight and metabolically healthy. So eventually they transform, and if they tend to transform, then this is something that increases their metabolic risk. Again, the study robustly confirmed the frequent transition from MHO to MUO and demonstrated a decline in metabolic health with age across the entire BMI range. Only participants who maintained metabolic healthy obesity over a long time, these individuals also had a 57% higher risk of CVD compared to women who remained in the metabolic healthy normal weight group. So clearly, friends, the fact that fat is still fit is just a myth. There's sufficient data which shows that obesity is detrimental to health. Metabolically healthy obese is a concept which is derived only from clinical observations, that a subgroup of people with obesity have a very normal metabolic profile. Their lipids look good, their blood pressure is good, their cardiometabolic abnormalities are not present. But most of the longitudinal studies have gone on to demonstrate that metabolic health is not a stable condition. And it not only depends only on the obesity or the weight, but it deteriorates with aging as well. Therefore, MHO is just a transient phenotype which can convert into and from metabolic unhealthy obese during the natural course of obesity in response to obesity treatments. Therefore, it is very important to be aware that an individual who may be fat but fit today may still be in a stage of transition to full-blown obesity with all the associated risks that I talked of, and therefore weight loss and lifestyle management is to be recommended to all individuals who are obese. And therefore, it is just a myth and not a fact. Thank you.
Thanks, Dr. Shalin.
Thank you,
You
Dr.
illustrate,
Yes.
you illustrate very elegantly, actually, how to be fat but fit, which is very important because the obesity is growing up. And if we have fat but fit people, so are not afraid of being fat. I believe that we have many questions for you, but it will be at the end, inshallah, of this session. Now, we discussed obesity, we discussed cardiovascular problems. I want now to introduce my dear colleague, Dr. Ines Shaltut, which is the head of Arab Association of Study of Diabetes and Metabolism. And she's a very known, well-publisher and eminent speaker in diabetes. And she will tackle a very important point now. She will talk about how more important obesity management or glucose control or both? So please give us the solution, Dr. Ines.
Over to Professor Inas.
We have problem in connection.
It's a recorded lecture. So we can start from. It's a recorded lecture. Can we start from the?
Yes, madam.
Okay.
Please.
Okay. Okay, no problem.
Stuti, please. Yeah.
We can't have the. Stuti, where's the audio?
Stuti, we can't hear her. Please check the audio and restart the presentation again.
Sure, sir.
Until we have the connection, I think we have one question in the chat box.
I'm going to talk about an important topic. Obesity management. Is it more important than glycemic control? This is my biography, Ines Chaltout. And let me start with the global prevalence of obesity among adults. Obesity is a rapidly unfolding healthcare crisis. We are having more than 800 million persons living with obesity, and the prevalence is highest among certain places in the world, like the Middle East. And my country, Egypt, is one of these countries, and also the United States of America is having a high prevalence of more than 30% obesity in adults. The twin epidemics of obesity and type 2 diabetes are on the rise, and from 1986 to 2000, the prevalence of BMI 30 or more is doubled, and BMI more than 40 is quadrupled, and extreme obesity of BMI 50 increased 5-fold. This is alarming. Increasing prevalence of obesity among children. This suggests that the epidemic will worsen in the future. The clear and present danger, these are groups of complications due to obesity, cardiovascular disease in the form of coronary artery disease, angina, myocardial infarction, heart failure, arrhythmia, and sudden death. And hypertension. For every 10% increase in weight, this will lead to increase 6 millimeter mercury mean blood pressure, and decrease in body weight will lead to decrease in blood pressure. GVT and respiratory complications in the form of sleep apnea, impaired respiratory functions, and Pickwickian syndrome. And to the right, we have a patient of obstructive sleep apnea, which is a serious complication of obesity and needs urgent management. And to the left, we have Mr. Pickwickian, who is a character in a novel written by the famous novelist Charles Dickens. This character was obese and having abdominal obesity, and when this person, Mr. Pickwickian, sits, he goes to sleep. Other groups of complications include hepatobiliary complications, fatty liver, hepatitis, calcular cholecystitis, arthritis, especially the weight-bearing joints like knees and pelvis, cancers, for example, breast cancer, colonic, prostatic, uterine, ovarian, and other types of cancers, and diabetes mellitus. 80% of diabetics are obese. Hyperlipidemia, especially hypertriglyceridemia, infertility, abortions, birth defects in obese mothers with BMI more than 40, and increased mortality in BMI more than 30. Obesity is linked to at least 9 types of cancers, including breast cancer, colonic and uterine, gallbladder, ovary and prostate, upper GIT, pancreas, and renal cell carcinoma. Other groups of complications of obesity include physical and social complications, and let me start with the physical complications. Patients usually come to our clinics even without any complication of obesity. They complain of tiredness, breathlessness, the presence of varicose veins, headache, edema, cellulitis, sweating, intertigo, and stress incontinence. Other social complications include sense of isolation, usually unemployed, with family or marital stresses, financial stresses, and depression. What about abdominal obesity and cardiometabolic risk? In the HOPE study, abdominal obesity was related to increased risk of cardiovascular events. Abdominal obesity in this trial increased the risk of developing type 2 diabetes. And abdominal obesity in the Paris prospective study predicted the adverse outcomes such as sudden death, where the abdominal diameter was a better predictor of risk of sudden death than BMI. Abdominal obesity also increased the risk of coronary heart disease and cardiovascular risk factors. Life expectancy decreases when BMI increases, and for those with BMI between 30 and 35, life expectancy is reduced up to 3 years, and for those with BMI between 40 and 50, life expectancy is reduced between 8 to 10 years. And for each 5 kilogram higher BMI, there is 40% higher mortality rate for ischemic heart disease, stroke, and other vascular diseases. The magnitude of the problem obesity has been linked to the development of multiple diseases, frailty, and diminished quality of life. Research showed that weight loss interventions, including pharmacotherapy and lifestyle modification, significantly reduce the risk of obesity-related comorbidities. GLP-1 agonists used to treat type 2 diabetes have been shown to be effective in promoting weight loss in preclinical and clinical trials. The combined central and peripheral action of GLP-1 receptor agonists promote satiety, decrease hunger, and ultimately reduce food intake. In the SCALE trial, among those with overweight and obese participants with type 2 diabetes, the use of subcutaneous liraglutide with a dose of 3 mg daily compared to another group of placebo, it resulted in weight loss of 6% over 56 weeks, while 9 randomized control trials, a largest proportion of participants achieved 5 to 10% of weight loss. Actually, in real-world evidence, the weight loss due to liraglutide is more than this 6% and 10%. In Sermont 4 trial, it evaluated the efficacy and safety of tirzepatide compared to placebo. At the end of 36 weeks, they achieved 21% mean weight loss. Tirzepatide appears to be the most effective available weight-reducing drug, producing average weight loss of 26%. Tirzepatide is a combined GLP-1 and glucose-dependent insulinotropic polypeptide GIP receptor agonist, the most effective currently available GLP-1 receptor agonist. It is used for both glycemic control and weight loss in the short and intermediate term. Future agents in this class might leverage additional mechanism of action for greater efficacy. We have other FDA anti-obesity medications. They are available already, like topiramate combination and naltrexone, bupropion. And let me start with the orlistat. It can lead to weight loss of 9.6% versus 5.6%. In the placebo group, with possible side effects on the liver, but it's actually safe, but weight loss is modest. The other, or the second medication, is phentermine topiramate. It can lead to weight loss of 7.8 to 9.8% with possible side effect of tachycardia and hypertension, and safety concern include suicidal thoughts, glaucoma, metabolic acidosis, and it is contraindicated in coronary artery disease and hyperthyroidism, and it's not recommended for long-term use, 12 weeks maximum. Naltrexone, bupropion, can lead to 5% weight loss compared to 1.8% in placebo group. Then the weight reduction is around 3.2%. The side effects include agitation, mood change, tachycardia, hypertension, possible withdrawal symptoms, and seizures. It is contraindicated in hypertension, hyperthyroidism, epilepsy, and those with history of suicidal thoughts. In case of less than 5% weight loss after 12 weeks of this medication use, it should be discontinued because it will no more adding benefit. It's not recommended in those below 18 years of age and in patients above 65 years of age. Maybe these age groups are sensitive to CNS adverse effects. What's coming in pipelines? Many anti-obesity medications are awaiting for final approvals. Among them, we have many medications or combinations. And let me start with rutatrutide, which is a GLP-1, GIP, and glucagon receptor triagonist. In phase 3 trial, up to 24.2% weight loss of baseline weight, and possible side effects were GIP side effects. The glucagon receptor agonist lead to enhancing lipolysis, inhibition of lipogenesis, increased energy expenditure, thermogenesis, and has an anorectic effect. The second medication is survodutide, another one in this group, still in phase 3 trial, and led to up to 19% weight loss. The third medication is cagrilintide, which is an amylin analog. It can lead to 10% weight reduction, and it was combined with semaglutide, and this combination led to 21% decrease in body weight from baseline. The fifth drug is orforglipron. It is a small molecule of oral GLP-1 receptor agonist. In phase 3 trial, it showed 14.7% weight reduction. All these medications in the pipelines give a wider scope for their use and future success competing with invasive metabolic surgery. Let me now speak about the effectiveness of bariatric surgery for weight loss. While some anti-obesity medications available now can result in weight reduction of 15 to 26% of baseline weight loss, these are the mean weight loss for different metabolic surgeries. For those with adjusted gastric banding, it led to a weight loss of 10.6%. Sleeve gastrectomy can lead to a mean of 17.8% weight loss. And gastric bypass led to 27% weight loss after 4 years, but 21% maintained weight loss after 10 years. And this is the different types of bariatric surgeries with the effect after 4 years and the effect after 10 years was maintained. What about the quality of life, which is a very important issue for the patients and for the family? The effect of anti-obesity medications versus bariatric surgery on the quality of life. Multiple studies prove beneficial effect of GLP-1 analog on the quality of life. Study conducted by Cajal et al. In young women with polycystic ovary syndrome and obesity treated with liraglutide. It resulted in significant improvement of their quality of life. In sustained trial with more than 3,000 participants, semaglutide showed improvement in health-related quality of life. Analysis data from 4,500 participants from 3 randomized controlled trials evaluating efficacy and safety of liraglutide proved improvement in metabolic parameters and health-related quality of life. It also showed that liraglutide effectiveness is caused by weight loss and by independent mechanisms other than weight loss. A meta-analysis compared 18 published studies on long-term outcomes of bariatric surgery. They found that health-related quality of life after bariatric surgery improves in the first 1 to 2 years after surgery, then deteriorates in the following 5 to 6 years. Again, what's the comparison between anti-obesity medications versus metabolic surgery? The long-term effect showed partial weight regain and return of certain cardiometabolic variables to baseline after medication withdrawal, with some serious unserious side effects like gastrointestinal complications and very rare cases of thyroid cancer. While bariatric surgery resulted in higher efficacy in weight reduction, but with significant percentage of complications post-surgery. Higher risk of complications, but in contrast, semaglutide presented a non-invasive alternative to surgery with significant weight reduction and lower incidence of adverse effects. The choice between these interventions should be based on individual patient characteristic and comprehensive assessment of risk-benefit profile. Another trial, 24 serious clinically significant adverse events were observed in lifestyle medical management cases compared to 51 serious adverse events in gastric bypass patients, denoting more health risk associated with bariatric surgery. Other beneficial effects of GLP-1 receptor agonists include cardiovascular risk reduction, renal risk reduction, stroke risk reduction, beneficial effects on NASH, possible associated anti-inflammatory effects on perivascular adipose tissue, reduction of incidence of prediabetes and diabetes, and all other beneficial actions beyond anti-obesity effects. Obesity and diabetes are two sides of the coin, and multiple studies shown association between obesity and type 2 diabetes. And these studies highlighted that early weight loss intervention in pre-diabetes significantly decreased the development of type 2 diabetes, and diabetes remission was a definition given by AGA 2024. Semaglutide and tirzepatide have been added to pharmaceutical arsenal against type 2 diabetes, and tirzepatide resulted in impressive remission rate ranging from 66 to 81% after 52 weeks. Obesity management, is it more important than glycemic control or not? Obesity management is of utmost importance, but according to the new approach of AGA for management of diabetes complication 2024, to reduce complications of diabetes, we have 4 pillars, starting with glycemic management. Then glycemic management is of utmost importance, followed by the blood pressure management, lipid management, and agents with cardiovascular and kidney benefit. And to do glycemic management, we should go for nutrition therapy and weight loss. Then lifestyle management is a fundamental element of type 2 diabetes care. Thank you very much.
Thank you, Dr. Ines.
Thanks a lot, Professor Inas, for a very wonderful and awesome session on management of type 2 diabetes, looking beyond glycemic control and addressing to the issue of obesity, which is one of the most common comorbidity along with type 2 diabetes. Please stay back for some questions toward the end. With that, we go to the last session in this, that is by Professor Naveed. What he is going to talk about is Professor Mohammad Naveed. He's going to talk about MASLD, the current perspective. May I have his CV? Yeah, he's Professor of Medicine and Hepatogastroenterology at Cairo University, member of Egyptian Society of Studying GIT and Liver Diseases, founding member and member of the Executive Board of Arab Association for Studying Diabetes and Metabolism, member of Gastroenterology, Endoscopy and Hepatology Unit, and he's a founding member and General Secretary of Gastroenterology Innovative Foundation for Training and Skills. So over to you, Professor Mohammad Naveed.
Yeah, hello, Professor Rajiv. I am so happy to be with this very prestigious and esteemed professors for a more successive year again. It's a very nice and very well organized event, and me representing my society, the ASD, I think we are so glad with this joint meeting with the Indian societies and with you, especially Professor. We consider you our dear professor and brother, and we hope always that you become so successful and your events are as successful as we can see. Thank you very much.
Professor Mohammed. Pleasure is all ours.
I have my slides.
Yeah.
I have a slides.
Yeah.
Can I have sharing the slide?
Yeah, you have the sharing link. Yeah. Share screen
Yeah,
at the bottom, green color button.
Yeah, I will share my screen.
Thank you. Dice is all yours for next 20 minutes.
Yeah, thank you very much. So can
You can go to slideshow, sir.
yeah, I'm trying to get to it, but it's a little bit stuck, I think.
Maybe you can unshare and share it.
Yeah. Okay, I got it now. Yes, I think so.
Yeah.
So I think now it's okay. Yes.
Perfect. Perfect.
Yeah. Okay. Thank you very much. So
Over to you, sir.
my talk is going to tackle a very important subject, which is the metabolic dysfunction associated fatty liver disease spectrum, or the now so-called metabolic dysfunction associated steatotic liver disease, and I will present the current perspective. Of course, our talk today is a very, very long story. It's 167 years old story of talking about fatty liver disease. It all started by this very prestigious and esteemed professor, British Professor George Budd in 1857, who described first the fatty liver and the fatty degeneration of the liver, and the story went later on through Professor Rudolf Virchow. Virchow is a very famous name, as we all know. He was this German pathologist who described the microscopic appearance of fatty liver. Later on in the 20th century, Charles Connor, another famous American pathologist, he described this association with presence of liver disease in a form of cirrhosis. And until 1980, this was unnamed disease, and they were calling it the hitherto unnamed disease, which is a hype or a trend of the unnamed disease. And then this was coined later on in 1986 by Professor Schaffner with the name non-alcoholic fatty liver disease, which survived over a quarter of a century until 2020, when there is an international panel of experts. They said that non-alcoholic fatty liver disease is a negative nomenclature. It relies on excluding other diseases rather than proving the presence of a certain disease. And then the name was changed to metabolic dysfunction associated fatty liver disease. And it is worth to note that those societies were Asian societies. It was the Maiden and the Basel, and they are all Asian societies at that time. The main purpose was to highlight the importance of metabolic dysfunction and metabolic syndrome as a causation for the liver disease. And there is heterogeneous pathogenesis, so it was not fair enough just to deny the presence of alcoholic consumption to get to this disease, and was recognized by the positive determinants. And this, of course, was the criteria for diagnosis, depending mainly, of course, about the steatosis of the liver with overweight, obesity, type 2 diabetes, or two or more signs of metabolic dysregulations, like the increased waist circumference, hypertension, dyslipidemia, pre-diabetes, elevated C-reactive protein, or insulin resistance. And this was much, much, much better. In fact, I do adopt the name metabolic associated fatty liver disease rather than a change which happened later on, 3 years later, from the Western societies and the EASL and so on, naming it the steatotic liver disease, and increased the spectrum of it, because metabolic associated fatty liver disease, it tackles the problem better. But of course, we all know what we are talking about. So the prevalence, of course, is high, and it's rather increasing, highest in the South America, and here in the MENA region, it's almost 36.5%. In South Asia, and so it's like 33.8%, and less in Africa. And we don't know whether this is just because of lack of the data from so many African countries, or simply because Africans are like the previous lecture of Professor Shalini said, they might seem to be fat, but they are fit, and maybe this is because causing them less liver disease. So about the mortality with the muscle, the pooled all-cause mortality is about 12.6 per 1,000 persons per year. The cardiac specific is 4.2. The extrahepatic cancer, yes, it causes cancer outside the liver, 2.8 per 1,000. And the liver-related mortality is about 1 per 1,000 person. Within the MENA region, Egypt accounts for almost one half of the muscle-related, liver-related mortality, with the prevalence of cases of 18.9%. So what about the outcomes? What is actually the spectrum of the problem of muscle? There is hepatic and extrahepatic outcomes like advanced fibrosis and cirrhosis, like hepatocarcinoma, obesity, type 2 diabetes, cardiovascular disease, chronic kidney disease, and as I just mentioned, extrahepatic malignancies. So what about advanced fibrosis and cirrhosis? There was a meta-analysis, huge meta-analysis on 8.5 million persons, including 86 studies in 22 countries, and it figured that the incidence of advanced fibrosis in MASH, which is a metabolic dysfunction associated with steatohepatitis, is almost 68 per 1,000 persons per year, and almost about 40% of patients with MASH having liver fibrosis progression. This corresponds to mean annual fibrosis progression of 0.09 with 95% confidence interval of 0.06 to 0.12, and the percentage fibrosis progression of almost 41%. During the past 3 decades, all of us, of course, have realized the very increased incidence of those having chronic liver disease and without having virologic etiology behind that. So it's the compensated cirrhotic patients, they increase twofold, and the decompensated ones, they have increased by almost threefold, which is a very huge drop. What about hepatocellular carcinoma? In the past 25 years, the burden of muscle-associated hepatocellular carcinoma has increased significantly, and nowadays, when we see a patient with hepatocellular carcinoma, it's more or less going to be due to metabolic associated steatotic liver disease rather than the hepatitis C and hepatitis B like we used to see. The annual incidence is about 0.45%, while MASH-related hepatocellular carcinoma is at much higher incidence, about 5%, and the cumulative incidence increased. And we all know that metabolic associated fatty liver disease is an independent risk factor for causing hepatocellular carcinoma, and it can cause hepatocellular carcinoma at any stage. It does not need necessarily to cause cirrhosis to develop hepatocellular carcinoma, and here comes the grave dangers of metabolic associated fatty liver disease. What about obesity? Of course, obesity, and we have 2 previous lectures tackling obesity, is the global pandemic now. 80% of patients with muscle are obese. Obesity prevalence estimates among patients with muscle is 51% with MASH, 81% with muscle. It's very high. Evidence indicates that obesity significantly increases the risk of developing muscle. It adds on to the problem of causing cirrhosis and adds on to the incidence of hepatocellular carcinoma as a more added risk to the problem. What about type 2 diabetes? The overall type 2 diabetes prevalence among patients with muscle is about 22.5%, up to 43.6%, varying from the studies. Approximately 80% with muscle may develop new onset type 2 diabetes with threefold higher risk. And of course, this will get us back again to the problem of hepatogenous diabetes, where the liver disease starts first, or type 2 diabetes, where the diabetes starts first, but this is not the spectrum of my lecture now to speak about it. Of course, type 2 diabetes will increase the incidence of hepatocellular carcinoma again and again. So when we take hepatocellular carcinoma We can see now that obesity is a problem, type 2 diabetes is a problem, and the metabolic associated fatty liver disease is a third problem. So it's estimated that individuals with type 2 diabetes, more than 50% of them having muscle, and of course, 90% having obesity. Cardiovascular disease, patients with muscle, they are at higher risk of developing ischemic heart disease, cardiomyopathy, cardiac arrhythmias, especially atrial fibrillation, increased cardiovascular morbidity and mortality, as we have seen. It is said that patients with muscle, 50% of them, they at least have one coronary stenotic, stenosis for them. A meta-analysis on 5.8 million middle-aged said that there is increase of 1.5-fold risk, increased risk of fatal and non-fatal cardiovascular disease events in patients with muscle. So there comes the terminology of liver heart connection because of that. What about the chronic kidney disease? And of course, the kidney is a very famous and important member of metabolic dysfunction associated problems, as we all know. The prevalence is higher among patients with muscle, with approximately 20 to 50%, and also another meta-analysis, including 13 studies and including 1.2 million individuals, showed that there is also a 1.5-fold increase in long-term risk of incidental chronic kidney disease, which is discovered incidentally at stages which is higher than stage 3, which is chronic kidney disease with glomerular filtration rate less than 60 milliliter per minute per 1.73 meter square, which is the surface area of the body. What about the extrahepatic malignancies rather than hepatocellular carcinoma? The incidence of adenomatous polyps increases 41.5%, and of course, the increase in incidence of colorectal cancer, esophageal carcinoma, stomach carcinoma, pancreatic, lung, melanoma, and even the incidence of metastasis, as well as cancer, kidney, and breast cancer, especially in women. All those incidences increase with the metabolic associated steatotic liver disease. This diagram now shows collectively the data that I just emphasized now as regards the advanced fibrosis, cirrhosis, hepatocellular carcinoma, association with obesity, cardiovascular disease, chronic kidney disease, diabetes, and even the extra hepatic malignancies. I will talk now about something that we rarely talk about, which is the economic burden of the problem. The economic burden of muscle has been estimated to be much considerable. In the United States, it is estimated to be 103 billion per year in direct costs. And of course, this in the United States, and we know that they have a grave danger of metabolic associated fatty liver disease, it is much higher than Germany, France, Italy combined with 27.7 billion euros, as well as added to them the United Kingdom with 5.2 billion. And it is not that, it's estimated that these numbers, these costs will be multiplied by 10 times in the next 10 years. It will become up to $1 trillion in the United States in the next 10 years, and about 334 billion in Europe in the next 10 years. This, of course, is very horrendous, and it is like the income of a country be wasted on metabolic associated steatotic liver disease. And that's why now the medical economics or the is now very important subject to be tackled nowadays. No data, unfortunately, available about the costs here in Egypt and the MENA region. So These problems and this current situation of metabolic associated steatotic liver disease, of course, needs definitive strategies to reduce this burden and to tackle this problem. For strategies, we need three lines to go in parallel: health policies, preventive health care, and advancements in the medical research and precision medicine approach. We all know now that there is a hype or a trend about the precision medicine, especially in the field of gastroenterology, where the treatment should be tailored to individual variations. So the treatment of maybe Mr. X is not like that, like the treatment of Mrs. Y, even if they have the same disease, like I will say shortly from now. So first thing is the health policies. Effective health policies is crucial, of course, to address the challenges of muscle. And this will depend mainly on the policy makers. Policy makers must comprehend and must understand the determinants of muscle and collaborate to formulate the tailored interventions to tackle and mitigate this related risk factors of the metabolic associated steatotic liver disease. This through governments and health organizations. They should increase awareness through effective and targeted health policies. They should prioritize the problem. And here in Egypt, in fact, we had a very good experience with hepatitis C, where the policymakers, they got convinced with the magnitude of the problem and the burden of the problem of hepatitis C. So they started the government and the health authorities here in Egypt. They collaborated along with the health organizations outside and so on. And we have created what was called 100 million health campaign for screening for patients with hepatitis C. And in fact, this was a success story backed by the policy makers. Policy makers must be convinced that metabolic associated steatotic liver disease is a grave danger to the society. So this brings us to the preventive health care, because prevention is better than cure, which is a motto, we know it in medicine, is very, 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 very in place when we tackle the issue of metabolic associated liver disease, which cannot start itself. It starts secondary to other factors which preceded it. So actually prevention is particularly relevant to metabolic associated steatotic liver disease. Unfortunately, global study, including 102 countries, showed that there is widespread neglect of this disease, national health agendas, and no country reported having a written muscle strategy. There is a CRC screening, breast cancer screening, even diabetes awareness and obesity, but there is no muscle written strategy. So this emphasizes the urgent need to implement such a strategy through monitoring and screening. So the last step, of course, is the advancement of medical research and precision medicine. There is no specific pharmacological treatment currently approved for metabolic associated steatotic liver disease. We all know that there is the thyroid receptor agonist that is tackling it, and it is just released. But most of the medications tackling this problem is mainly targeted to energy intake, energy disposal, control of diabetes, decrease the lipotoxicity of the liver inflammation, and so on. But nothing is specific to the muscle. And here comes the name of precision medicine, where personal customized precision medicine involving targeted therapy, lifestyle modifications that differs from one person to another, and personalized risk assessment to every and single individual alone. Of course, this needs a medical research which is pivotal in uncovering the underlying mechanisms and the discovery of an innovative, specific, precise metabolic associated steatotic liver disease pharmacotherapy for the I hope that through my lecture, I emphasized the current perspective of metabolic associated steatotic liver disease. This lecture is going to be recorded and present on my YouTube channel. I will be glad if you visited me there and had fun with my other lectures, and thank you very, very much. Thank you very much.
Thank you, Professor Mohammed, for a wonderful lecture on MESLD. I think it is a hot cake, which is one of the most preferred or one of the most sought after topic these days when we talk about management of comorbidities in setting of type 2 diabetes. So before we close, we have 6-7 minutes. Do we have any questions in the chat box? Or shall I get one comment from each speaker?
I have a
Professor,
question, Dr. Chawla.
yeah. Dr. Meena, yeah.
Madam, you said the complication of obesity is frailty. So can you please elaborate on that? Are you talking about sarcopenia in obesity when you said obesity leads to frailty? Please explain.
Sorry,
You're giving the question to me or to Professor Naguib? To myself.
Madam.
Okay. We're going to have another.
Your slide said obesity leads to frailty.
Yes, because usually patients with obesity are having a kind of weak muscles. They are also complaining all the time of fatigability. And there is something called sarcopenic obesity affecting middle age group. We're going to complete the discussion about this topic in one of the next lectures, maybe on Sunday.
Professor Inas, you have talked about obesity and getting a preference of managing obesity even before the glycocentric or glucocentric approach, because we need to address today obesity as a comorbid situation in setting of type 2 diabetes, not talking of glucocentric approach. Do you have a hierarchy fixed in your own Egyptian guidelines? What is the availability of these drugs in your country? And do you have any algorithms to put in place when it comes to clinical care or standard care?
In my country, we have liraglutide and semaglutide as injectable. We're going to have tirzepatide maybe soon next year.
Okay.
And we have one oral FDA approved, one of them together with the orlistat also. We have the orlistat. The injection anti-obesity medications are giving very good results, even more than results shown in randomized controlled trials. I can't say that obesity management is better than glycemic or it's more important than glycemic management, but obesity management help glycemic management and reduce the burden of diabetes and sometimes leads to remission of diabetes. So they go hand in hand. We cannot say that one of them is favorable than the other one.
But is it a standard care, and do you have guidelines in place?
We're putting now a recommendation for obesity management, and it's going to be announced soon, and when to use anti-obesity medications and when to use bariatric surgery. And we will be very happy to share the results and consensus with you to take your opinion also in the consensus.
That will be great, I think.
We have a question in the chat box. Ozempic is good or not for reducing weight? Of course, Dr. Inas very beautifully answered that yes, it's showing actually better results than what you actually have read in the randomized control trials, because ma'am, in our country, we still don't have Ozempic. We just have the oral semaglutide, which is Rybelsus. One question to you, because our population has tolerability issues when it comes to higher doses of GLP therapies, So, with Rybelsus also, the moment you go up to 14 milligrams, a lot of patients drop out because of the gastrointestinal effects. How is it responding in your population? Do you see similar problems, or are your populations taking it better?
If people will suffer from 14 milligram Rybelsus or oral Ozempic, imagine that the anti-obesity dose may reach 42 milligram.
So this heroic dose, I don't know how patients will tolerate. For my practice, I know this may be not the drug label. I go for the lowest effective dose. I don't go to the highest dose without necessary use. If liraglutide is going to give effect with 1.8, so I stop at 1.8. Maybe this is not convenient with the pharmaceutical company, but I stop at 1.8. And also for Ozempic, I stop sometimes at 1 or 1.5 if this concentration will give the effect. When we use the lowest effective dose, it's going to give better tolerance by the patient and the long use or longer use by the patient.
I think Professor Gamila talked about newer drugs and a newer approach towards management of diabetes, and she focused on protection of organs, organ protection in diabetes. Dr. Gamila, do you agree? Early days when we were talking of only the glucocentric approach, in spite of couple of drugs which were available till 10 years ago, also there was no reduction in morbidity and mortality with CVD or with CAD. With this change approach, which is now there since last 10 years, ever since the CV outcome trials, EMPA-REG and DECLARE are available, do you see any change in or reduction in cardiovascular mortality in the setting of type 2 diabetes?
Yes, yes. Thank you very much. I'm very honored to share in this meeting, and I think that's the glycocentric approach to prevention of multi-organ damage. We've just shifted from a glycocentric approach to prevention of multi-organ damage. I think this is a very important issue, and we are seeing radically and interesting and promising changes in treatment of patients with type 2 diabetes. And definitely it favorably modify the prognosis related to fundamentally nephro-cardiorenal outcomes. So I think since no more than 2 decades, the pharmacological armamentarium for the treatment of people with type 2 diabetes has basically consisted of the use of biguanide, sulfonylurea, insulin sensitizer, and insulin. But really a great amount of information has been accumulated, and we really, through the results of new molecules, such as SGLT2 inhibitors, based on many robust data, and this is arising from the experience of numerous studies. So I think even the quality of life have been changed. We found that many patients are living more, and maybe the best that we can elaborate from this is the age span or the span of the personnel, because with Egypt, so far as you know that in the 50s, the age span in the Egyptians, for example, was around 48. Now we're witnessing much increase in the age span, and we are now having ladies, for example, around 74 years old, men 73. So I think it added a lot.
Thanks a lot. I am sure that with this change approach, coming generation, we might have reduction in macrovascular risk and cardiovascular mortality with oral anti-diabetic drugs. So with that comment, we will like to close this session. Professor Colin Dine has already joined in for his session. Thanks a lot to Professor Enas, Gamila, Mohammed, Naguib, and everyone, those who have logged in. I think it has been a wonderful scientific feast with the ASD and CMRE. I'll request all of you to stay back for another 3-4 sessions, which are in the pipeline with Professor Colin Dine, Professor Antino. Then we have Professor Usha Chirram and Professor Adi Mehta also likely to join. So over to you, Dr. Meena, to conduct this session. Maybe have Dr. Meena's introduction. Dr. Meena is going to chair this session with Dr. Professor Vinod Kumar. I think Dr. Vinod Kumar may get late, so I think I'll request Dr. Meena. She's a very dear friend. She's a senior consultant physician and diabetologist, has done diploma in diabetes, Middlesex University, UK. She's a senior visiting consultant and diabetologist at Sir Gangaram Hospital, a state-of-art center in this part of the world. And she's a wonderful person, a very good orator. And I'm sure she's going to conduct this session in an excellent way. And Professor Vinod Kumar is again a very senior consultant physician, former professor of medicine at AIIMS, and professor and head department of endocrinology at PGI, subsequently at AIIMS, and is patron now for RSSDI. Over to you, Dr. Meena, please.
Good evening, everybody, and a very warm welcome. And thank you, Dr. Shalini and Dr. Chawla. It was a wonderful afternoon session with the Arab Society. And now, a very warm welcome, Dr. Colin Dayan. Can I see his, can I project his
Sudhi, can we have his
slide?
CV, please? Welcome, Professor Colin Dayan. Good
Good
to have
evening,
you.
Professor Colin, sir.
Missing you
Welcome back.
physically this time.
Dr. Colin, it has been my proud privilege to have met you personally. And today, I'm actually proud to read out your incredible achievements. So you trained in medicine and at University College, Oxford, and Guy's and Charing Cross Hospitals in London before obtaining a PhD in the immunology of Graves' disease in the laboratory of Mark Feldman. You then spent a year as an endocrine fellow at the Massachusetts General Hospital in Boston, USA. You became a consultant senior lecturer in medicine, diabetes and endocrinology at the University of Bristol in 1995, and the head of clinical research at the Henry Wellcome Laboratories for Integrative Neuroscience and Endocrinology in Bristol in 2002. In 2010, you were appointed to the chair of clinical diabetes and metabolism and head of section at Cardiff University School of Medicine, and became the director of the Institute of Molecular and Experimental Medicine in 2011. You have a long established interest in translational research in the immunopathogenesis, immunopathology of type 1 diabetes and thyroid diseases, and you have published widely in both areas. You are the Joint Research Office Director in Cardiff in 2021. So I'm honored to actually introduce you and to chair this session. And the floor is all yours for your talk on preventing type 1 diabetes. How close are we?
Good evening, Professor Colin. It is wonderful to have you amongst us. Unfortunately, this time you couldn't make it to the physical conference, so virtually we are going to enjoy your talk. You have been a backbone of this program for close to 11 years now, ever since we were partner in Cardiff University along with Professor Mohammed. And I think this is for the first time that we are not able to have your company in the physical conference. So we will have to, agree with and I think we are going to be enlightened with your virtual presence and your session. Over to you, Professor Kodan.
Thank you, Meena. Thank you, Rajiv. And I'm sorry not to be with you. You know how much I enjoy coming to work and teach with you and discuss. I always learn so much from those conversations. So thank you for the opportunity to present today. Let me see if I can just share the slides properly. That's important to know, isn't it? So here we go. Maybe my title is very slightly different from the one you gave, but it is really the same topic. So delaying progression to type 1 diabetes, an emerging reality. And I would just say a lot of this is going to sound a bit like, science, but I've learned from this group that you're very scientific as well as clinical. And so I thought to myself, I'm going to challenge you today to think about the future and where we're going to go, particularly with type 1 diabetes. In the end of the story, you'll see there's a little twist that might apply to type 2 at some point, if we haven't solved that all with GLP-1s. Okay, so I have some disclosures. So to kick off, just a reminder that type 1 diabetes is not a metabolic disease, it's an autoimmune disease. And that means we have an intact islet here, which has brown is the insulin, red is the glucagon, and then we have insulitis. These are the lymphocytes that are infiltrating the islet and then destroying it till you get to this point when there's only glucagon left and all the insulin is gone. That is the underlying process. And in general, as we treat it today, we don't treat this process. We just wait till the process is finished and then replace the insulin. So the principle is, if it's an autoimmune disease, then if we can slow or halt the autoimmune process, we can delay or even avoid the need for insulin therapy. And I think many of us forget just how difficult insulin therapy is. I know you all know this. But when I say to my students, do you know what? You can't have hypoglycemia without insulin therapy. It's the insulin therapy that causes the hypoglycemia. It's not the diabetes that causes the hypoglycemia. So this graph is showing HbA1cs in children in the UK, and it's the National Diabetes audit, a pediatric audit in the UK. It's showing you that in the first year, most children managed to achieve a pretty good HbA1c. These are the sort of newer units, but we're essentially talking about 7 to 7.5%. But then as the years go by of diabetes, and this is cross-sectional studies, it gets worse. And it gets worse, particularly in the teenagers over here. It's better in the children. Why would this happen? And almost certainly this is related to the loss of endogenous beta cell function, which happens in the first 5 years after the diagnosis. The last bit goes. But then it relies on the compliance of the individual, and teenagers find it harder to comply than smaller children under control. So what I'm really trying to illustrate here is that if we could go backwards, if we could restore that beta cell function here, then surely everybody could achieve a good HbA1c, whether they're a teenager or they're not a teenager. So it's an immune condition, so we might want to approach the immune system, and I appreciate that not all of you spend a lot of time thinking about the immune system. It is reasonably complex, but what this picture is trying to show you is the gray areas here. These are not parts of the immune system. These are biologics. These are selective ways we have, you may recognize a few of them, of intervening with different parts of the immune system. And that's important because when we think about immunosuppression, we often think about organ transplants, and they have a high risk of side effects, and that's not worth doing. That's not worth a trade-off for insulin. But these drugs that I'm just describing, so-called selective immunosuppression, are very much safer. And they're widely used in areas like arthritis and skin diseases, and their risk is low. Ultimately, we might be able to have what I call unvaccines that boost the immune response just to the islet cells, and then we wouldn't have to affect the rest of the immune process, and their risk would be very low, but we don't have this at the moment. There's a lot of work in this area. I'm not going to talk more about that today. So just to illustrate this is psoriasis, and here there are at least 11 biologics that are licensed for psoriasis. Now, is that a worse disease than type 1 diabetes? Why have all these drugs been licensed for type 1 when there are no drugs licensed for for psoriasis, when there's no drugs licensed for new onset type 1 diabetes? And you will know when it comes to rheumatoid arthritis, it's enormous. Here's 50 different biologics that are used targeting many different aspects of the immune system in rheumatoid arthritis. And this is not necessarily listing the new oral drugs, the JAK kinase inhibitors that are starting to be used as well. So we're way behind the curve in terms of treating an immune disease, and there's lots of options out there. Well, I've discussed with you before that there are options, and this list is getting longer, of the things that have shown to preserve beta cell function in what I'm going to call stage 3 type 1 diabetes, which is when you're newly diagnosed and you still have some beta cell function left. So I'm just going to illustrate this with a couple of the trials in the last 4 or 5 years. This one is golimumab, which is anti-TNF. And I want to point out that this is an injection given subcutaneously every 2 weeks. So that's a lot easier than a subcutaneous injection given 4 times a day. And showing you here measurements of C-peptide from baseline and how here's the placebo declining over the first 52 weeks, or the first year, sorry. And here is preservation by the injections of golimumab. Notice, however, it is still beginning to fall here as we approach the first year. And here's quite a relatively recent one, baricitinib. So that's one of these oral active agents that's used in arthritis. In fact, it was used in COVID as well, which is why over 1 million people have received this tablet, baricitinib. But it was trialed in type 1 diabetes, and it worked very nicely by the Australian group here. Here's baricitinib and their C-peptide versus the placebo again. And we just published about a month or so ago, another agent, uscatinimab, which is actually given subcutaneously every 2 months and is used for psoriatic arthritis. Over 100,000 people have received this for psoriatic arthritis, so we know its safety very well. And I want to illustrate the safety this way around, which is looking at the risk of serious infection. And by that, I mean people being admitted to hospital for infection. And it could be a UTI, it could be a septicemia, it could be a cellulitis, but it's bad enough that you had to come into hospital. If you're on a renal transplant, you need about a tenfold. It's about tenfold higher than the healthy population. You've got a 10 times risk, about 6% a year, of being hospitalized for severe infection. But we forget that diabetes also increases your risk of infection, poorly controlled diabetes by about 7 times, and just type 1 diabetes itself by 3 times. When you look at where the drugs fit into this and what their risk is, they're right down here. Rituximab is a B-cell agent used for lymphoma, and that's got a slightly higher risk, and I'm not advocating the use of that at this moment. But here's anti-TNF, which is similar to that golimumab that I showed you. TKI, which is similar to the tyrosine kinase inhibitors, that's the baricitinib that I showed you. And here's the drug that I just described, ustekinumab. You really can't tell that it's got any increased side effect profile compared to control. So those are the reasons why we think it is appropriate to engage with this. I want to touch on another drug that's had prominence, real repurposing of a drug that you're all familiar with, called verapamil, which of course is a drug used for cardiovascular disease, for hypertension and for angina and for dysrhythmias. But it seems to have an effect, particularly on the beta cells via the calcium channels. And it stops the hyperglycemia and the cytokines. These are cytokines acting this way from inflammation, causing in the end apoptosis of the beta cell. So it acts through this molecule, TXNP, to protect the beta cell. So it's not acting on the immune system, it's protecting the beta cell. And this was reported in 2022 here. These are patients, again, new onset C-peptide, and you can see that after for the first year and the second year, there's preservation, maybe even a slight increase in the C-peptide production. Here's the controls, and here are people who stopped after 1 year and it declined. And as you might expect, where it's declining in C-peptide, the insulin dose increases. Where the verapamil was continued, they didn't need an increase in insulin dose. A lot of people challenged this trial because it was relatively small, about 25 individuals, but it's now been replicated in 2023 in a study in 7 to 17-year-olds using verapamil again. This was actually a 2-by-2 study where one arm was intensive therapy with pumps to try and preserve beta cell function. The other arm was verapamil. The pumps, the hybrid closed loop pumps, didn't work. The verapamil did work. And here's the level of C-peptide at the beginning, and here's the level at the end. There was almost no change when there was a fall in the placebo group. That's what's being illustrated over here. So it does look like it does work. And in fact, we've just completed earlier in the year recruitment to a 3rd trial in adults of verapamil. We call the VERA-T1D trial. Here's the recruitment curve. And we've now got 135 patients in the trial, and that trial will report in the middle of 2025. So that'll be the 3rd trial to try and confirm this. I pointed out to you that even with good agents, there's a fall off, there's a decline in C-peptide after the first year or so. So we believe that actually the next step is to use combinations. And verapamil gives us an option of doing combinations, because if you put 2 immune agents together, you might worry about the infection risk. But verapamil doesn't do that. So this is what we call a platform trial that we're about to start in a couple of months' time, where everybody gets verapamil. There's no placebo. Everybody gets verapamil, and they either get one other agent, either with golimumab, with baricitinib that I mentioned, and this is another agent that's proven effective, AETG or thymoglobulin. So this means you only have one control group, and you can move more quickly through the different combinations. And I think that would be an important way of improving what we do. And for those who are interested in clinical trials, this results in savings. So if you have just one arm, you need about 32 in each arm. If you have 2 arms, you need 46 placebos, which is less than 64. So you save 18 subjects. By the time you've got 4 arms running at the same time, so we've got 3 here, you're saving about 64 subjects you don't need, because you don't need to replicate the placebo arm every time. So it becomes a very efficient and quick way of finding out combinations of treatments. Well, do we need new treatments when in fact we've got hybrid closed loop, which works very nicely? Thank you very much. Well, there's nothing better. The one thing better than hybrid closed loop is no insulin at all. Do you remember we mentioned at the beginning that if you get in early enough, in theory, you can preserve enough beta cell function that you won't need insulin. You won't even need the hybrid closed loop. So we have this picture now of the staging of type 1 diabetes, which some of you may be familiar with. So the idea is that these people are going to end up with diabetes, 90 to 100%. Then they enter a stage down here when they've lost more beta cell function, when they're dysglycemic, like impaired glucose tolerance, but they're not yet progressed on to needing insulin. And stage 3 is when they have the ADA criteria for diabetes, 2-hour glucose of more than 200 milligrams per deciliter, 11.1, and then, potentially soon after that point, they're going to start on insulin. So that's why we talk about these different stages. What I've been talking to you about is immune therapies at stage 3. Well, what about getting in at stage 2 or even at stage 1? Could we do that? This is just the evidence that people with 2 or more antibodies, so these are people with 2 antibodies to the islet, or 3, that means anti-GAD, anti-IA2, anti-insulin, anti-ZNT8. And you can see that with 2 or 3, that they, in time, in maybe 15 years, almost all of them, certainly more than 90%, have progressed to developing type 1 diabetes. If you've just got 1 antibody out of the 4, the progression is much slower and it might not happen. But for these people, we say they're in stage 1, it is going to happen. You will need insulin. And this is the evidence that it happens more quickly if you're dysglycemic. So these groups here were dysglycemic. These had normoglycemia. And you can see that the dysglycemic with antibodies group, what we call stage 2, almost all of them, 80% or more, had developed their diabetes within 5 years. So we really know how quick this progresses, and we know who to engage with. And if you ever doubted it, this is just the 2022 criteria, has been updated. The ADA criteria confirms these 3 stages. So can we get in at stage 2? And the answer is yes. And this trial reported in 2019 that many of you will be familiar with, used a drug called teplizumab, or anti-CD3, in stage 2. So it's in relatives, and they've said at risk, but they are going to get type 1 diabetes, and they had to be dysglycemic to get into this trial. And the course of infusions over 14 days, that was the only treatment. There were no more treatments after that. And indeed, the only reason it was given fractionated over 14 days was because of side effects. If you give it too quickly, you get a cytokine release syndrome. It's really only one treatment. But they did this right at the beginning. And you can see that 5 years later over here, there was, instead of 80% of them developing diabetes, it was 50%. So it resulted in a mean delay of about 2.5 years initially, and with further follow-up, it's closer to 3 years. So in other words, 3 years when these people didn't need insulin, otherwise they would have needed it. How does it work? Because all of these things work in a slightly different way. This is broadly how we think teplizumab works. So here you've got your beta cells here, and the red are the autoreactive T cells, and they're killing the beta cells. And the idea is that the teplizumab arrives and it pushes the autoreactive T cells into an exhausted state. It doesn't deplete all T cells, because that would be very immunosuppressive, but it targets cells that are very hyperactive, T cells that are very hyperactive, and just, if you like, exhaust them, pushes over the edge. They don't necessarily die. Some of them will do, though. And in terms of side effects, it's very minimal, but during the period of infusion, the 14 days, you sometimes see this rash, which is a sort of skin desquamation, not usually too dramatic, and it resolves after that. And this is what happens to the T cells during the period of infusion. They drop after 5 days, and then they recover. What's remarkable is that within about 4 weeks, they're back to normal levels. Now, if you had a true T cell depleting or immune depleting agent, this would last for at least 6 months before a new population could come back from the bone marrow. So this is not depleting. It's what we think is marginalizing them. It pushes them out of the circulation, maybe into the lymph nodes, and then they come back. And this is important because it means you're only at risk of infections during this 2 to 3 week period. There's a slightly increased risk of things like zoster and so on. Beyond that, there's no evidence that there's long-term infectious risk. However, the effects, as you've just seen, can last for nearly 3 years. So this is some of the long-term follow-up data on that, to 4 to 7 years. So that drug, teplizumab, has now been licensed in the US in 2022 as Tzield. It's now licensed also in UAE and 1 or 2 other countries around the world, but it's going through approval processes in Europe at the moment. And it will change the way we operate, because you have to find the patients to be treated. They're not going to come to you. But we like this idea. We're this idea of our research group in the UK of moving towards insulin-free T1D. Maybe that's a phrase that you might want to think about. So this idea of getting in early so that you can have as many years as possible without the need for insulin. Now, a lot of people say to me, well, does it really matter? You know, why don't you just get on with it? They're going to need insulin. So I want to emphasize the advantages of insulin-free T1D of that period. Said before, there's no hypoglycemic risk, 3 years when you can't have a hypoglycemic episode, pretty much. There's no need for lifestyle limitation. You don't have to think about your diet or exercise or what you're doing every day or your adjustments for your dose. You're free. You don't have to monitor, maybe once every few months to make sure it's not progressing, but certainly not daily. You don't have to wear CGM. You don't have to prick your finger on a regular basis. And very importantly, and this group knows it very well, if you've got good glycemic control, which you must have during this period, otherwise you would have progressed, it must be in the non-glycemic range, you are not accruing a risk of long-term microvascular complications. So you get 3 years of free control. And we know that 6 or 7 years of good control in the DCCT trial delayed things for 30 years going down the line. So it's very valuable control early in the disease process. Not surprisingly, improved quality of life. You get other spin-offs, is that if you screen, it's less likely that you present for the first time when you're diagnosed in ketoacidosis. On the right, it's showing you that still around 20% of new cases in England are diagnosed in ketoacidosis to the point where they need either critical care or certainly hospitalization. And this lady is crying because her son died about 6 or 7 years ago at DKA before diagnosis. So it was at the time of diagnosis, and that shouldn't happen. And if you screen people and they know they've got the antibodies, then it dramatically reduces the need for hospitalization because you can just start insulin as an outpatient over a few months because there's no big rush about it. And the DKA rate drops dramatically here in 3 different studies showing you how it's dramatically reduced. So that's an advantage. But screening is quite hard work. Only 3% of relatives and 0.3% the general population will be double antibody positive and will develop diabetes. So this was screening of 90,000 children in Germany. This is age 2 to 5. And again, 0.3% were multiple antibody positive. And of those, about 80% are in stage 1, 10% are in stage 2. And oddly enough, 10 to 15% already have diabetes and they didn't realize they had it. They hadn't got to the point of needing insulin. They were pre-symptomatic, if you like. People worry that if you screen people and tell them they're going to develop diabetes, that they're going to be very anxious. And of course, that happens. But it seems to settle quite quickly. They get used to the idea and the anxiety levels, that's what this is showing you, over a period of about 12 months, fall to background levels. And the anxiety levels are much lower than that sudden diagnosis that happens at the moment when people within a few weeks suddenly get very sick, admitted to hospital with ketoacidosis. So just to show you some of the more recent developments in this area. So now there's a lot of population-based screening activities happening, and this publication tried to draw that together from around the world. And just this year, we've had consensus guidance on monitoring of people when they are double antibody positive. So, you know, I mentioned that you screen people, but what do you do after that? It could take several years before they develop. How do you monitor it with HbA1c, with CGM, with finger pricks? Or what should you do? HbA1c actually works pretty well. And they show a sort of, in this consensus guideline, how you progress through into your repeating the test, first of all. If it's positive, then you have pre-symptomatic diabetes, and then you go on to metabolic monitoring through to assessment. And that's all in that paper. But I think there's more happening in this space. I said I'd mention it just towards the end. So we've mentioned closed loop. We've mentioned FDA approving that first drug. But just last week at the EASD, Vertex, who are taken over from ViaCyte, reported the use of stem cells in 14 patients, like an islet transplant. So they took an induced stem cell line, they converted it into beta cells over a period of a few weeks, and they infused that into patients. And after a year, the majority of them were off insulin. But the problem with that is it's like an islet transplant. You still need immune suppression because it's an allograft. It's not an autoimmune graft. But this paper was also presented, which is just amazing, at the ASD. And just to summarize what they did, they took islets, and these were, I think they were derived from stem cells, and they knocked out HLA class 1 and 2, which are the molecules that present to the immune system. And they made them essentially an invisibility cloak. And then they reimplanted them into rhesus monkeys, and they, without any immunosuppression, they had very good levels of C-peptide and very good glucose control. So this is an islet transplant without any immunosuppression, which would be an amazing thing if that plays through, and they're gradually going into clinical trials. So to summarize, we have the tools to identify and intervene prior to insulin dependence in type 1 diabetes. And if we can do that, that confirms health and quality of life benefits that are more than any advanced insulin therapy can provide. However, it does require population screening, because I didn't say, but 90% of cases come from the general population, only 10% come from relatives. It's a major effort, but it reduces acute illness at presentation. It stops those people getting sick before they come into the hospital. And it's certainly worth thinking about in relatives. So now we've got the first licensed preservation therapy, although we don't have a therapy from diagnosis. It's enough to trigger the idea that we should start screening. So I would say, but insulin-free T1D, it's not an if, but a when, and the practicalities of it and making it cheaper. And so I like to picture it this way, that, you know, we discovered insulin over 100 years ago, but we could work to the eradication, at least of childhood type 1 diabetes, by delaying the onset, picking all the children up and delaying the onset more and more until diagnosis of diabetes in childhood becomes a rare event. Thank you.
Thank you so much, Professor Colin Dare. So would you like to tell us about your new type 1 plus project that is going on with multiple immunomodulation? And you, so will it decrease the dose of teplizumab? You will give multiple drugs, verapamil with teplizumab. And another question, so that you can take both of them together, is that we see some type 1s not prone to microvascular complications in spite of having bad blood sugar controls. So is it that they have some residual C-peptide, and through immunomodulation, if we could preserve at least 5% of the beta cells and some C-peptide throughout their lives, is it a possibility that they may remain free of microvascular complications? So, incredible work that you are doing. It's not easy to test multiple drugs, and we know the JDRF funded trial 1+ that you are doing. So I'm so proud to be listening to you here, and thank you, Dr. Chawla and Dr. Jaggi, for allowing me to chair this. So I'm actually very, very honored. And so my questions to you about the plus trial, the type 1+ with multiple drugs.
Two very good questions, Mina, and I know you'll make sure I keep the time, so don't, cut me off. Right? I'm passionate about this subject. So let's take the second part first, which is the preservation of C-peptide. There is certainly good evidence that very small amounts of C-peptide preservation protect you from hypoglycemia. You need more of it to improve your glycemic control. You remember seeing those people from diagnosis, the HbA1c went up, they were good in the first year, and then it slipped. They've got about 20% of beta cell function left at that point, but it's going by, they'll halve it in the first year, so it'll be 10% and so on. So every little helps. So it is good to preserve it. And when you think about that, teplizumab, for example, when they get the diabetes, they still have more beta cell function. There's still things you can preserve. And your idea that just keep it going a bit for longer, even if they need some insulin, it does make it easier to control. I suppose that was my point about the good HbA1c at the beginning. So I agree with you that every little helps, if you like, in that regard. However, to come back to your other question about the sort of people who are protected, no, I need to just touch on the people who are protected. My understanding of it is that very few people are protected from retinopathy. Rajiv might want to come in here, that eventually everyone gets retinopathy if they have poor glycemic control. But in things like, neuropathy and in renal disease, and maybe also in macrovascular disease, it is quite variable. And there does seem to be somehow people who get away with it, even though they have very poor glycemic control. So, and better people on the panel than me have looked into some of the genetics of this and how that process happens. We don't know who those people are going to be. So, we would like to try and protect everybody, but that is certainly an area of interest. And I suppose all the new drugs to protect people who go on, SGLT2s and so on, that protect them, are going to make more people able to get away with it, even with poor glycemic control. I guess what we're trying to do is to remove that terrible burden of insulin and those people who deal with it very, very badly. Finally, just to deal with the platform trial side of it, the problem is that, newly diagnosed type 1 diabetes is not that common. In the UK, we said that a general practitioner will see about 5 cases in their lifetime of a new diagnosis actually happening. You see it more often because they're referred to you. But it means that the population for trials is relatively small, and we want to answer lots of questions in a small population. That's where these so-called platform trials can be advantageous. Cancer has used these very effectively, and they did it in COVID very effectively, because it means you can, I didn't show you that you can actually have what's called an adaptive design, where I think you probably know this, but you can do an interim assessment and drop one of the arms because you think that's not working. That gives me time to introduce another arm and stop recruiting to an arm that's not going to be successful. So that is the plan, to be efficient.
I think that is true even for type 2 diabetes also, that not everyone who has a poor glycemic control, 1/3 of them may not even develop microangiopathy, which should be otherwise a very linear complication relationship with type 2. That is more true even in type 2 with lot of genetic predisposition for microangiopathy in families. And you very rightly said, type 1 also, that type of relationship we can see quite often.
Thank you.
It was wonderful listening to you, Professor Colin. It has been a wonderful session. And of course, we are missing your presence in our physical conference. Hopefully, we'll surely have you next time. Over to you, Dr. Meena, to call the next speaker.
So from immunomodulation in type 1, we move back to type 2 diabetes. And it's an honor and privilege to introduce the next speaker. Professor Ceriello has published widely in the area of diabetes with 500 original papers. Currently is the president of the European Association for the Study of Diabetes Study Group on Diabetes and Cardiovascular Disease. Dr. Antonio Ceriello has also served as board member of the 2019 European Society of Cardiology Guidelines on Diabetes, Prediabetes, and Cardiovascular Diseases, developed in collaboration with the EASD. From July 1st, 2016, he has been appointed as the editor-in-chief of Diabetes Research and Clinical Practice, which is the official IDF journal. Professor Antonio Ceriello is the winner of the 2004 Camillo Golgi Prize of the EASD, and in 2017, he won the Helmut Mehnert Award during the IDF 2017 meeting. So he'll be talking to us now on early use of SGLT2 inhibitors.
Hello, everybody. I'm very sorry that it wasn't possible for me to be in person to this very important and interesting meeting, but I would like to share with all of you something very relevant for the modern management of diabetes, meaning why we should use as soon as possible an SGLT2 inhibitor for the treatment of diabetes. What we'll know is that an optimal management of diabetes includes a glycemic control, the weight management, managing comorbidities, of course, all these avoiding the side effects, including, if not the most important side effect, the hypoglycemia. So what about glycemic control? About SGLT2, we know very well, maybe we have forgotten that these drugs are very active in improving glycemic control. They were born for glycemic control. And we have evidence, for example, here related to canagliflozin, that alone or in combination with metformin, sulfonylureas, also with insulin, glycemic control is very well improved. But this is not only true for canagliflozin, but also for dapagliflozin, empagliflozin, and more recently confirmed also for ertugliflozin. So the class works very well in improving glycemic control. However, we learned in the last years that a comprehensive management of hyperglycemia is not only related to lower A1C, but we have to pay attention to several aspects of hyperglycemia. And it has been suggested that if you want to really optimize glycemic control today, you need not to control A1C and fasting blood glucose, but also you have to improve the time in range to avoid the glycemic variability even in short and long term, to reduce postprandial hyperglycemia at 1 and 2 hours, and of course, reducing the risk of hypoglycemia. So this is the modern approach for controlling hyperglycemia. So it's really worth of interest to know that the SGLT2 are able to improve all these aspects of management of hyperglycemia. So they not only can reduce A1C, but also can improve the overall modern glycemic control. What about weight management? Of course, the weight management today is a very cool aspect of diabetes management. We have strong drugs like GLP-1 receptor agonists, but we also know that the SGLT2 inhibitors have the potential of reducing weight. You see here that this is true again for canagliflozin, for dapagliflozin, and empagliflozin, and more recently, it has been confirmed also for ertugliflozin. And if you look at the forest plot of all these trials performed with the SGLT2 inhibitors, you see that all are able to reduce body weight. So the second aspect of diabetes management, weight control, is also tackled by SGLT2 inhibitors. What about managing comorbidities? We learned in the last years that I'm speaking as a diabetologist, that one of the most important frequent comorbidity in diabetes management is the presence of heart failure. It's one of the most the very early developed complication in diabetes. And very often the cardiovascular disease, particularly heart failure, is joined by the kidney disease. And today we speak about cardiorenal disease. What is really important is that when these two conditions are both present in the same person living with diabetes, there is an increased risk to die for this complication. So to control this complication is mandatory in people with diabetes. And we learn, I'm just summarizing with this meta-analysis, that the SGLT2 inhibitors are very, very effective in protecting the heart, particularly not only for cardiovascular events, but specifically also for heart failure. They are very powerful in improving the prognosis for heart failure. So this is really an important news in the management of comorbidities in diabetes. But one less recognized aspect of diabetes management is the possibility of the existence of the so-called metabolic memory or legacy effect of hyperglycemia. This phenomenon was demonstrated first in the DCCT study and then confirmed also in the follow-up of UKPDS. What means metabolic memory? Means that epidemiological and prospective studies support that the long-term influence of early metabolic control on clinical outcomes, meaning that an early glycemic environment is remembered in the target organs, and the concept of a metabolic memory is of diabetic vascular stresses persisting after glucose normalization. So it's very important to control in the best way glycemia, particularly from the diagnosis of the disease. This until now was the only possibility we had. And evidence is there. You will have a clear explanation that if this bad glycemic legacy drives the long-term risk for complications, which has been confirmed, for example, in the long-term, in the post-hoc analysis of KPDS. You see here that in green you see people in the womb. There was a decrease of 1% of A1C after 1 year from the diagnosis, or from 5 years in blue, or from 10 years in red. And you see that after 20 years, the timing of reducing of 1% A1C was really important in keeping a better outcome for complications. And more recently, in this article published again regarding UKPDS in Lancet, it has been demonstrated that this beneficial effect of early glycemic control is kept even after 4 years after the trial. So we were wondering, because UKPDS was using only metformin, sulfonylureas, and insulin, and the SGLT2 at the time of this trial were not available, we were wondering, what about if we introduce an SGLT2 in the treatment of diabetes? And we used the huge database of the Italian MD Annals, which is a database including more than 500,000 people followed for 20 years. And we selected people not having any complication at entry in the study, and we check what was the perspective even an SGLT2 was introduced after 1 year, 2 years, or 3 years from the diagnosis. First of all, we were able to confirm the existence of the legacy effect of hyperglycemia in this database. But for the first time, we were able to show that if you introduce an SGLT2 within 2 years from the diagnosis, the legacy effect is out. So the SGLT2, if we early introduced in management of diabetes, are able to counteract the appearance of the metabolic memory. And particularly relevant, you see that this works in people having an A1C higher than 8. So not at good glycemic control, but the not acceptable glycemic control. And the conclusion of this study was that these findings advocates a wider and early use for SGLT2 inhibitors. How can work an SGLT2 in avoiding metabolic memory? The metabolic memory is supposed to work through the overgeneration of free radicals at the mitochondrial level induced by hyperglycemia, leading to a DNA change. And you see here the hypothesis summarizing this possibility. And it's worth to remember that recently we have very strong evidence that SGLT2 inhibitors are able to regulate the intracellular antioxidant defenses through different pathways. So the hypothesis is that inhibiting an SGLT2 receptor, you can improve the defense against the free radicals which are induced by hyperglycemia, leading to metabolic memory. But it's also important to note that we know very well that hyperglycemia is linked to the development of complications through the overgeneration of free radicals at the mitochondrial level. You see here the summary of all the pathways engaged by high glucose through overgeneration of free radicals leading to diabetic complications. But it's again worth of interest to know that all the aspects of hyperglycemia, which I have described, meaning hypoglycemia, time in range, glucose variability, postprandial hyperglycemia, all are working through the same pathways. In other words, when you have these conditions, they superimpose the overgeneration of free radicals to chronic hyperglycemia, explaining why they contribute to increase the risk for complications and why avoiding this situation, you improve the prognosis for the complications. I think also that from clinical point of view, it's worth of interest to show this data, real world data, showing that when an SGLT2 or also the GLP-1 receptor agonist is included, added to the metformin in the treatment, you have a real benefit in preventing complications, particularly cardiovascular complications. So everything is going in this direction, supporting the need for early use of an SGLT2 to avoid the appearance of complications in people living with diabetes. What about safety? Oh, I think that this is well known. I'm just showing this recent meta-analysis showing that an SGLT2 inhibitor is really related to very, very low risk of hypoglycemia. So about safety, there is no doubt that they work very well. This is the ADA 2024 standards of care. And you see here that on the left side, on your left side, these standards of care recommend that if you have people high risk for cardiovascular disease, but more particularly for heart failure and chronic kidney disease, you must use an SGLT2. But you see also on the right side that the control of glycemia is there as well, the need to control the weight. So it's clear that you have to control the risk for heart failure, particularly kidney disease in people living with diabetes. An SGLT2 offers a very good solution because in one side, not only protects against this cardiorenal risk, but also improves glycemic control, not only in terms of A1C, but also in terms of overall glycemic control, which is now considered today, and plus improving the possibility to avoid metabolic memory. So it's very comprehensive treatment for diabetes. And you see here that this is probably the best approach for to harmonize the glucose and cardiocentric management of diabetes. Several years ago, we suggested that we need to harmonize glucose and cardiocentric approach of glycemia. And we suggested that if you have somebody not at risk for cardiovascular disease, you can use metformin plus DPP-4 inhibitors according to verified study. But if at risk, you can add an SGLT2. In other words, you can start with this kind of combination as early as possible. But I think that now we have evidence suggesting that the right place in this context is an early use of SGLT2 inhibitor, because in this way you really can merge glucose control and cardiorenal prevention. So, in our opinion, this is today is the best option. And this concept has been stressed in a recent commentary we published in Lancet DDE, in which we suggest that with all these data support the possible benefit of an early use of SGLT2 inhibitors in diabetes management. So in conclusion, early use of SGLT2 inhibitors is strongly recommended today. This is the best way to prevent complications in people living with diabetes. Thank you for your attention.
Thank you, Dr. Antonio Ceriello. And Shalini, do we have any questions or do we proceed to the next talk? So I can see my dear friend, Dr. Usha Sriram. Usha, it's my honor to chair your session and to introduce you. So you are meeting the leading authority on women's health, and she's done extensive research and has great experience on women's health, particularly women's metabolic health and more than health research. And she's also a great advocate of women's health on several national and international platforms. She's a graduate of Madras Medical College, an AB in internal medicine and AB endocrinology, diabetes and metabolism. She's the head of the Department of Endocrinology, Diabetes and Metabolism at the Voluntary Health Services, Chennai. She's the president of the Indian Society for Bone and Mineral Research, founder of Divas, which is so dear to my dear friend Shalini and me, special interest in gestational diabetes, women's health, osteoporosis, preconception care, and medical ethics. So over to you, Dr. Usha.
Okay. Thank you, Meena, for that extremely kind introduction. I absolutely, adore you guys. So thank you for chairing this session, and it's an honor and a pleasure to be here. And shall I go ahead and share my slides, or Shalini?
Dr. Usha, you want any help?
Yeah, I'll go ahead and share it because then it's easier to control it. And
Ma'am, you want us to share from our side, or do you want?
No, I'll share it. In case I have a problem, I'll let you know.
Okay, sure, ma'am, sure.
Okay. Can you see it now?
Yes, ma'am. You just need to make it full screen.
Of
Yeah,
course,
perfect, perfect.
From Chennai, but currently in the US. Thank you, Professor Chawla and Dr. Shalini, for this opportunity to speak on this very important topic, which is focusing on women and thinking of that as the best opportunity.
Ma'am, you want us to run the audio also?
No, I can do the audio. So,
okay. Stuti, can you stop the audio?
There are many facts that we need to take into account. Why we need
Stuti, can you stop the audio?
No, they can.
Everybody's audio is off only.
So one is that
we can hear it in the background.
Currently,
somebody has started the backend. किसी का YouTube या delegate link चालू है. So that they have to.
Can you mute everyone then?
It's okay. It's okay, Shalini. We can just do this. Outcomes of diabetes.
Yes, ma'am. Now I think you can do it. Stuti, start it from the beginning. Stuti, can you start it from the beginning?
Ma'am, it is done by Dr. Usha Sriram only. We are not sharing her slides. She's sharing by herself.
specific to women, and some have a more outside. That
agonists than men. Initially, we thought the price would be a deterrent for women, but in the urban setting, I have seen that more men are ready to buy GLP-1 receptor agonist for their wives or, for them to lose weight along with management of diabetes. Dr. Usha, your take. Are more women receptive to GLP-1 RAs, whether oral or injectable?
So strangely, people who are even have needle phobia and will not take insulin will take GLP analogs when it is primarily for weight loss purpose. So that barrier is usually not there. More women are overweight, as we know, and after listening to Dr. Cerulio's talk that people at high risk and more women, as you will hear from my presentation, are at high risk for diabetes and its complications, so should be getting it. And they are receptive, but the challenge for women is their affordability. So I think, Meena, you shared with me last year sometime that you had more male patients on semaglutide than women patients, when it really should be the other way around.
Dr. Shalini will agree now that it is changing as we are as more and more people are losing weight along with dropping their HbA1cs with oral semaglutide. More women are receptive for the weight, which you just said. So are women more weight conscious than HbA1c conscious, which means more than health? Are they using it for cosmetology? Dr. Shalini, would you like to answer that? Do you also feel more women take it? We are easily able to convince them because they want to lose weight?
You are partially right, because most often, when you talk about a woman, when you have a woman with type 2 diabetes sitting in front of you, our focus is more on how do I lose weight rather than how do I get my A1C down. And most of the times it is for cosmetic reasons, besides all the other reasons that we keep talking about. So yes, that is why I think if you give them a GLP-1, they tend to take it for a longer time if they start responding well to it. So the motivation is the weight loss that they get rather than the glycemic control that they get with the GLP-1 therapy, because they feel that if this is a drug that is going to make me lose weight, they're ready to, try it out for a little longer, try out the higher doses, whereas men get demotivated very fast if they get those GI side effects, They're not too motivated to go up to 14 milligrams and then continue it for a longer time compared to women, where I think this definitely tends to be one more factor, in addition to the metabolic and all the other reasons that we talk of.
So,
shall I try again?
Yes, ma'am, you can try again. We've downloaded your PPT. We're just about to, it's not downloading because it's a heavy file. We're trying to download. It's not happening.
So
can you try sharing it once
again?
I will
try one more time. And if it's if it is a recording, that's okay. We'll go ahead with that. If it is my Professor Chawla, and thank you, Meena. It's just such an important topic that we are addressing today. Oh my God, again, the presentation is starting. Okay. Are women, maybe slightly few million more men. It's also because the world has a lot more men. But if you look at projections between 2021 and 2040, the difference between men and women. Said all this, why is it so important, and why did I want to talk about diabetes in women? Because even though the prevalence of diabetes seems to be about equal in men and women, more women die every year from diabetes across all. Shalini, I think there is some confusion, and I, really, I apologize.
No
But
issues,
what I can do is I can actually.
ma'am. 2 minutes, I'm sharing.
Thinking of that as the best opportunity for prevention of diabetes and using a life course approach. There are many facts that we need to take into account why we need to consider women as I like to call the low-hanging fruit. So one is that the prevalence of diabetes is currently around 50-50, but it's clearly women are going to overtake men because of the increased risk factors I will show you. The mortality is higher in women across almost all continents except North America. The complications, the adverse outcomes of diabetes are higher in women, from heart disease and stroke and end-stage kidney disease to cancers. And the guidelines for diabetes care really does not take into account gender different, sex and gender differences. Those who have diabetes. And we're also talking about prevention of diabetes itself. And when policies are made, it's very important that we put together, we use a gender. Mentioned, this slide shows the drivers of diabetes, in addition to the usual genetics and obesity and sedentary lifestyle, unhealthy eating and smoking, gut microbiomes. But if you see here, things like pregnancy, parity, multiple gestation, gestational diabetes, genetics, social determinants of health, environment, pollution, all these, and some of these are very specific to women, and some have a more outsized role when it comes to diabetes in women. And we've had this because we have not been very gender smart and gender sensitive and gender specific in our approach. You kind of used the male model as the default model and looked at diabetes prevention and diabetes care as a one-size-fits-all approach. And that is really what I want to talk about, that we've had this very myopic view of diabetes care as this one-size-fits-all model, and not taking into account the unique life cycle of women. And as I mentioned before, I really consider focusing on women as the low-hanging fruit for diabetes prevention. So while there are so many drivers of diabetes, for today's discussion, I thought I would look at pre-diabetes, obesity, gestational diabetes, low birth weight, and also preconception care as opportunities for prevention. Pollution and social determinants of health and environment, and obviously genetics is non-modifiable. And age is non-modifiable. So these are other larger things that as individuals we will be able to contribute, but these others that we are going to talk about as physicians involved in the care of persons with diabetes, we can contribute much more. So the first one is obesity. And addressing obesity in women is very important because one, even the new NFHS 5 shows that obesity is on the rise, more so in women, and women have certain events that happen in their life, like pregnancy and delivery, and part of the time when there's gestational weight gain. Many women gain weight even postpartum, which puts them at risk for gestational diabetes in the next pregnancy or diabetes in the near future. And also, women have traditionally their sedentary pursuits are greater, like television watching, and some of it may be because they don't have the agency to do the kind of things that they want to do, and they are forced to sit at home or do the kind of activities that does not involve a lot of physical activity. And what is the consequence of obesity in women? I just want to show you maternal obesity and pregnancy outcomes. When you look at these new Asian guidelines, not only complications like miscarriages are more and preterm deliveries are more, we know that complications like gestational diabetes and gestational hypertension, large for gestation babies, these are much higher, which again feed into increased risk of diabetes in the offspring in the future. And if the mother gives birth to some has maternal complications, she is at risk for chronic diseases in the future. And the other thing is an obese woman also has the microbiome changes, which leads to poor outcomes in the offspring. And this is so we are all not only talking about prevention of diabetes in the woman herself, also prevention of diabetes in the next generations. Now, what about pre-diabetes? I put this picture just to say this is something kind of looking out into the future. What does pre-diabetes lead to? And this study, called as the CAR study, which was done in Chennai, Delhi, and Karachi, shows high burden of pre-diabetes in 3 large cities in South Asia, and what they've shown is very high risk of pre-diabetes in women of reproductive age. And we know that pre-diabetes can translates into diabetes in the not so distant future. So again, pre-diabetes in women have to be addressed. We also know that women are at greater risk for heart disease, whether age adjusted or multiple adjusted. And why does this happen? When there are sex differences in visceral and subcutaneous fat and their association with the time of diagnosis of pre-diabetes, women tend to stay in the pre-diabetes stage for at least a good 2 years more than men, while that the accrual of the fat happens. And this translates into greater cardiovascular risk that is accrued in those 2 years. So addressing pre-diabetes, not only for conversion to diabetes, is very important. It also addresses cardiovascular risk. So this is very important. 2 birds. Low birth weight. This data from the UN shows that underweight mothers are very common. The blue dots are India, by the way, very common in India. Anemia is common, which also can lead to low birth weight. Obesity is somewhere around 10-15% in this, but considering that we have over 300 million women in the reproductive age group in our country, that again, those numbers translate into huge numbers of women. So what happens if a baby is undernourished or low birth weight? We know about the DOHAD hypothesis, the developmental origin of health and disease, that proposes that environmental conditions during fetal and early postnatal development influences lifelong health and capacity through permanent effects on growth, structure, metabolism. So extremely important. And not just the low birth weight baby. throughout her life, childhood, puberty, reproductive life, midlife, later life, increased risk for diabetes and heart disease in the woman if it's a girl child who is born low birth weight. And if you look at birth weight, that itself increases the risk for the odds ratio for gestational diabetes. So if the baby is born small, she is at greater risk for gestational diabetes. And baby who is born small is also at increased risk for metabolic syndrome and type 2 diabetes in the woman. And the mother of the small gestational, the small for gestational age baby is at greater risk for cardiovascular disease. Very important to keep in mind. And some very, very new data that shows that the baby who's born small has early onset of chronic disease, which we know. But one of the other things, new things, is sarcopenia. That babies who are born small, they are at greater risk for future sarcopenia, and that we know again fuels other chronic diseases. Now, what about preconception care? We know that unintended pregnancies are very, very common, especially in low and middle income countries. And as I mentioned, there are now currently over 300 million people, and it's only rising. We have not seen the peak yet. So when you have this large numbers of women who are in the reproductive age, we should really consider this as our ideal group for focusing all our attention for diabetes prevention. Because not only can these women be put on a healthy trajectory so they do not develop diabetes through education, empowerment, proper screening, counseling. Also, good preconception care can make sure that they do not develop complications during pregnancy and they do not deliver a baby who is either small or big, that we want to optimize birth weight. So all of these things are achieved by preconception care. Unfortunately, anything that we start after the pregnancy starts, either nutritional interventions or behavior changes, really does not impact the outcome a whole lot. So all our efforts will have to get started before the pregnancy starts, and that includes contraception advice, screening for diabetes and anemia, and a good history regarding all their behaviors and nutrition and family history and health history and genetic history, behavioral history, mental health, and then address that so that this woman does not develop complications during pregnancy. Now coming to the big one, which is gestational diabetes. Really, if I want to, off the low-hanging fruit, pick the one which is the lowest, this is the one, gestational diabetes. As you can see on the side, the risk factors for GDM are many, some of which we may not be able to change much in terms of ethnicity or age or family history. But there are a lot of things that we can look at. We can look at weight, we can look at counseling a woman with PCOS, we can look at physical activity, we can look at her exposure to endocrine disrupting chemicals. So many opportunities for us to address women regarding women with PCOS, to talk about prevention of GDM, because we know that women who have had GDM are at 10 times greater risk or 11 times greater risk for type 2 diabetes in the future. And when we say future, it's not in the very distant future. 5 to 10 years from the index pregnancy, 50% or so have developed type 2 diabetes. And if the woman develops gestational diabetes, either again during the second pregnancy or during the second pregnancy, her risk for future type 2 diabetes goes up even higher, around 15-fold. In spite of this, if you look at this slide, everything is about missed opportunities. We miss all opportunities for bringing the women back for follow-up after their delivery. The health system itself is not geared for that. And the women need to be counseled, and we have to put in strategies that will bring them back that we counsel them, we take care of them postpartum. I mean, literally not let them out of our sight for the rest of our life. And that's the way we can really make sure that cardiovascular disease or development of type 2 diabetes, we can try our best to prevent diabetes. But there are many barriers to postpartum follow-up, and we did a survey within our in Chennai, where we were able to find out that there are so many reasons why women do not come back for follow-up testing, which including things like I'm afraid of coming to the hospital and exposing myself and baby to infection, or I won't have privacy to breastfeed, or it may be something I don't want to be on a treatment. My family says that if I take the baby out or if I go out, there'll be an evil eye, or I can't take care of my older children if I have to leave. The testing facility is not easily accessible. So many reasons. And why I'm showing all these reasons is we need to find ways to overcome these. If a woman says that I cannot come at 6 weeks, okay, it's between 6 and 12 weeks. And if she's not able to come by that time, let's see if we can do it, right after that. Or let us find ways to do the testing at home. Or if she has a glucometer, and I think every woman with gestational diabetes should really have one, she can test it at home and send us the results. So many ways we can work around this and see how we can avoid not testing the women. And because if we find diabetes or pre-diabetes, we can quickly initiate treatment. And if she's normal, we can still counsel her on lifestyle and just postpartum weight gain and breastfeeding, which has been shown to decrease the risk of diabetes in women who have GDM. We can counsel on, which we need to counsel earlier, but we can keep reinforcing the importance of exclusive breastfeeding for 6 months after delivery, a little longer if possible, and then complementary breastfeeding. So all of these things we need to do, because when we look at this, the NCD risk in mother goes up with each pregnancy, and higher risk trajectory is exacerbated by GDM pregnancies. But look at also the risk in the first offspring. So when we're talking about diabetes prevention, we are talking about next generation and the next generation and the next generation. So how do we solve this big problem of diabetes? Awareness, awareness, and awareness. Awareness that, awareness among the healthcare providers and the health system, policy makers, that women, diabetes in women is a very different, as I like to say, it is different, and it is difficult, and it is dismissed and dangerous and deadly. And we have to address pre-diabetes, obesity, low birth weight, PCOS, provide preconception care, and prevention of GDM. I know we talked about what we can do after she has developed GDM, but by doing school programs and college programs and talking to the families in the community, how can we prevent GDM? Policy changes, as I mentioned, and a life course approach than a myopic and narrow view of women's health, activism and advocacy. And I'm very grateful that I have Meena and Shalini and a whole team of people who are working on this with me, and very, very grateful for that. And cohesiveness and collaboration. And by empowering our frontline health workers, they, I think, are our biggest strength, and we need to empower them with the necessary knowledge and tools on diabetes prevention, because women have a unique life cycle. And we keep harping on lifestyle, it's very important, but their life cycle is so different, and many things can happen to women. So we need to look at from the time of they're pregnant, so that the baby who's born is neither small nor large, and the girl child she's properly nourished, and the adolescent girl knows about healthy behaviors and slowly the education about diabetes and gestational diabetes, because there's a paradigm shift. Suddenly one morning a woman cannot wake up and become a healthy mother to be or healthy mother. She has to be a healthy girl, healthy woman, healthy mother to be, and then a healthy child, has a healthy baby. Otherwise she is going to develop gestational diabetes, then develop diabetes, then develop cardiovascular disease, and her beautiful, wonderful life is going to get cut short. So, this is the reason why it's so important to focus and have this life course approach for the prevention of diabetes and look at women as our best and ideal opportunity for prevention. Thank you all so very much. And there have been wonderful models like the Go Red for Women that showed us that you can actually decrease the risk, as this slide will show you. And the beauty is when we work on women, it actually also trickles down to the men, which you can see here also, that when it comes down, the heart disease mortality came down in women after the initiation of the Go Red project, which is really what we have been working on, something like that for diabetes. And it's really time. And I borrowed this slide from a colleague of mine, Amanda from Australia, who says it's time that we stop admiring pathology and start treating it. And we really need to put in all the measures possible to prevent diabetes. Thank you so much.
Thank you, Dr. Usha, for that insightful presentation. But we are so sorry, due to paucity of time, the time constraint doesn't permit us to ask any questions. And we shall proceed to the next CMRE symposium.
Thank you so much. Thank you, Meena. Thank you, Dr. Chawla.
Thank you so much, ma'am. So with that, I think we start the last symposium of the day today. And Dr. Adi Mehta is already present with us. We're trying to upload his presentation. It's taking a little time. So yeah, there he is. Welcome, sir. A very good morning to you.
Good morning, sir.
And so good to see you.
Wonderful to have you amongst us. I'm sure it must be very early morning and it's always a challenge for you too. You are muted, sir. Unmute yourself. Dr. Amitesh is there. Dr. Shalini, introduce him for chair. Dr. Amitesh Agarwal, Professor Amitesh Agarwal and Professor Madhu were supposed to chair.
So to chair this session by our very esteemed and beloved speaker, Dr. Adi Mehta, we have two wonderful chairpersons, a very senior and esteemed Professor Dr. S.V. Madhu. Sir is Director Professor, Department of Endocrinology, Center for Diabetes, Endocrinology and Metabolism at GTB Hospital, and Dr. Amitesh Agarwal, Director Professor and Unit Head, Department of Medicine, UCMS and GTB Hospital, Delhi. Dr. Amitesh, welcome. Dr. Madhu, sir, is he logged in? I can't see, sir. So anyways, Dr. Amitesh, please introduce Dr. Adi Mehta, sir.
Now click insert. Yes.
Okay. What do I do next?
Yeah. So now we have our esteemed guest, Dr. Adi Mehta from US, and today he's going to talk on the liver, a villain or a victim of diabetes, and we are all eager to actually hear his views on that. He has been a faculty and attending staff at Endocrine Metabolic Institute at Cleveland Clinic since 1993, and he has been an associate professor in the Department of Endocrinology in University of Manitoba in Canada, and he is a member of American Association of Clinical Endocrinologists and the Endocrine Society and the American Diabetes Society. Over to Adi Mehta, sir. We are all eager to hear to you, sir.
Thank you very much. Just give me. What do I do? You hit.
Yes, you click here.
Yes, sir. Click here and okay. Start.
To be able to present. So forgive me, I'm not very good with technologies. I'm electronically handicapped. I would like to thank you very much for giving me this opportunity. And we're going to be discussing a relatively interesting topic in that I've sort of made it a little more personal, rather Dr. Chow made it more personal. Is the liver in diabetes a victim or a villain? And I think it's very important to sort of go through this very quickly. I think all of us are aware that the liver has a number of functions, among them being metabolic and storage. There's excretory, protective, and detoxification drugs, which we're not going to discuss now. What affects us the most is the metabolic function. And the metabolic function is, in the first instance, to do with carbohydrate metabolism. The whole idea of gluconeogenesis, glycogenolysis, the idea of hepatic glucose output being regulated for utilization as fuel. Then there's
Sorry to interrupt, sir.
Sir, your slides are not moving.
Sir, can you please put slideshow? Can you just
go. We'll try this. So again, thank you very much for the invitation. And as I was saying, the liver has a number of functions, and we don't worry about all the rest of them. What we worry about is mainly how it works in metabolism. Carbohydrate, lipid, and protein are all going to be relative functions of how the liver is going to function through this. And so when you think of the 4 pillars that's involved in glycemic control, you think of liver, adipose tissue, pancreas, and muscle. And in a very histrionic fashion, you can think of them as the 4 musketeers. And what we're going to do today is we're going to concentrate only on the liver. So under normal conditions, the muscle and the pancreas improve glycemic control. However, in the case of an expanded adipose tissue, you need significant functions of the liver to do the job. So I'm going back to a certain extent to what was said in the last lecture, which is that in fact, a lot of what happens in life happens or starts to happen in utero. So in the uterus, if the fetus is faced with stress, especially nutritional stress, its first goal is to say, I have to preserve glucose for brain function, because brain is actually the working model. So therefore, in an effort to preserve glucose for male function, it starts to make it more difficult for other tissues to get glucose. The concept of insulin resistance is established in utero, and it is established by some epigenetic changes, not genetic changes, the epigenetic changes, which then sets up a system that says you're going to restrict fetal growth because you don't want to spend too much energy on that since you're trying to protect the pregnancy. You're going to increase the capacity to store, that is the concept of obesity. You're going to adapt metabolic pathways to try and protect a food at all times, that you're going to be worrying about starvation, not only in the uterus, but outside the uterus, because that's what the baby or the fetus thinks, that if there's starvation in the uterus, there must be the same outside. We're not far wrong. And then going to have some adaptations in terms of how many cell numbers you've got so that you don't waste too much effort on making cells. I think you need to keep the 4 restrictions that happens in utero when you anticipate that there's going to be starvation in the world which are coming in. So if you now got the ability to say every time you eat, you're going to put something into storage. And the question is, you're going to put it into adipose tissue. The fact is, if adipose tissue is rich in adipocytes, it will take a little bit and put it in all the adipocytes. So therefore, you will always have the capacity to store more. That is the upper panel. That's healthy expansion. You get adipogenesis, you get an increase in insulin sensitivity remains, and there is no evidence that that fat is going to get inflamed. On the other hand, if your adipocytes are markedly diminished in number, now they're going to be hypertrophy, they're going to be packed much more heavily with fat. Now you've got an increase in cell hypertrophy. You decrease insulin sensitivity because the cells can't take any more. And in fact, what happens is once this fat starts to become overfull, it becomes stressed, it becomes inflamed, and you get a low grade of inflammation, and you now start getting macrophage into the fat tissue. That's lipotoxicity. This is going to predispose to allowing more of this fat to leak into ectopic fat sites because the visceral fat or the subcutaneous fat is slowly being overwhelmed by just the amount of storage you got to do. And that's what sets you up for ectopic fat accumulation, which is going to be in the liver, in epicardial tissue, around the kidney, and most importantly also in the pancreas. So I just told you that this is what happens. That in fact, as your fat becomes more and more stressed or packed, you're going to turn or bring on a macrophage function, and you're going to increase. Now you're going to go from the fetal insulin resistance to increasing your insulin resistance or building on the increasing resistance even more. Now, once you started doing that, you get the spillover effect. So now not only are you getting fat coming in from your nutrients, but you're also going to start packing in fat from what that can't be stored in the adipose tissue. So now you've got a circle that says you're going to further accumulate fat in the liver, You're going to further accumulate fat in the muscle. And most importantly, and for terms of diabetes, you're also going to start accumulating fat in the pancreas. So now you've got a liver that's full of fat, a heart that's full of fat, and that's going to pay, you're going to pay a high price for that later on. But in fact, a pancreas that is starting to get fat, and therefore its functional capacity is going to be impaired by this deposition of ectopic fat within the pancreas. So basically, you have to understand that this is an ongoing process that will not be stopped, and that is in fact going to contribute to the development of issues. So here's the liver. Basically, it takes up the glucose nutrients, it takes the free fatty acids from adipose tissue, it starts to work with it. The extra work increases insulin clearance, you're unable to regulate hepatic glucose output, you get hyperglycemia, which induces hyperinsulinemia, and then the whole circle starts. So in fact, the liver was trying to help. It's a victim. It's not necessarily a villain. It basically is doing work beyond its capacity to try and work through the loads that is being seen in the process of dealing with nutrients. So the intrauterine environment establishes the background insulin resistance, but a rise in the free fatty acids induces a hepatic insulin resistance, which is then going to predispose to increased amounts of fat content within the liver. And this is going to cause an inflammatory drive occurring within the liver. And that's why when we look at steatohepatitis, it's the reason why it's called hepatitis is because you get an inflammatory process, and you're going to therefore get the fibrosis that goes along with the process of destroying the kidney, destroying the liver. So when you look at this, here you've got the concept that you're actually inducing further insulin resistance just by what we're doing in terms of dealing with extra nutrients that the body was never supposed to get, because it was never geared to be able to live in a fully non-starved environment. So what does the liver do? The liver is going to take this fat and is going to slowly work it in to a number of different pathways. These are outlined here. Basically, you're going to oxidize it to form energy. You're going to synthesize triglycerides. You're going to pack into VLDLs and secrete into circulation, and you will now get hepatic cholesterol that's going to be occurring within the liver. Again, the liver remains a victim, not the villain. And so if you look at the central role of the liver in this whole process, basically what you see is the liver is unfortunately faced with a load of nutrients coming from the gut, from adipose tissue, from de novo synthesis, and is working overtime to work through this. And in the process of this, it cannot deal with the extra, and it starts to leak it out. So when you look at the molecular profiles of increasing of type 2 diabetes, there is the exposome, your liver lifestyle, and you get a diet. But on top of that, you've got metabolites, branch chain amino acids, glutamine, glutamate. All of those factors start to change the concentrations in terms of the workload for the liver. At the same time, your proteins, adiponectin, your leptin starts to change to overcome these effects. You've got transcripts that change and make adverse profiles. And most importantly, you go back to the gut itself. The gut microbiome tries to help by changing its intrinsic microbiome. And that also is going to, in fact, affect how you're going to deal with all of this. So in a very general way, the liver is looking at a number of attacks and having to deal with a number of these attacks. As an example, fructose is a very important example. Fructose is very commonly seen in all the sweetened drinks that you have on cake. In a study done in pediatric and adolescents with NAFLD, they showed that the total intake of calories, fat, and carbohydrates was similar in this group of patients, whether they had NASH or they had just steatosis. However, the NASH patients had a higher intake of fructose, clearly indicating that fructose is an ongoing trigger for worsening systems within the liver. And the microbiome, we have discussed that, and the speaker before me discussed the importance of the microbiome. This is bacteria-derived metabolites which influence inflammatory and metabolic processes in the liver. The fecal metabolic signature of fatty liver and diabetes is completely different from that of healthy individuals. You have remember that there is now a science that says you can take fecal transplants from individuals who are very thin, put them into patients who are fat, and you can change the way the fat people now metabolize. So in fact, fecal transplants has been shown to also work in this metabolic situation. I know it's been shown to work in C. difficile. So again, the liver is the victim. The increased production of VLDL induces an arterogenic dyslipidemia, which we all know. Insulin resistance in the liver, adipose tissue, and muscle leads to hyperinsulinemia. And this is now going to increase the workload on the pancreatic beta cell. And that is going to then ask for further changes in in how insulin is going to be secreted. Together with this, you're going to change a whole different sense of rheology, and you're therefore going to set up the inflammatory process of inflammatory disease that is type 2 diabetes. Even a mild increase in liver enzymes. In this retrospective study in Korea of 13,000 individuals who are free of diabetes and hepatic steatosis at baseline, re-examined after 5 years, newly detected fatty liver was associated with about a 2.5-fold increase in incidence of diabetes. The risk for diabetes was also increased by worsening of the fatty liver. And so it's clear that setting up the the liver having been asked to work harder, asked to do all these things, and thus damaging itself, is going to end up hurting the whole organism. Similarly, in a US study looking at MRI studies, you showed that there was a significant prevalence of fatty liver disease in people with diabetes. And in fact, there's some concern that says that the few people who don't have fatty liver disease and have what is considered type 2 diabetes may actually have a different variant. So that brings us to the whole concept of the fatty pancreas. As I said, the liver cannot deal with the extra fat load. It starts to leak out. We know that it leaks out into the heart, and that's diabetic cardiomyopathy. We know that it leaks out into renal fat and how it works there. But we also know that it starts to accumulate within the beta cell. In the beta cell, this accumulation of fat sets up pancreatic inflammation. So not only are you asking the beta cell to work harder, but then you're also limiting its ability to work harder by changing the intercellular prospect and increasing the inflammatory process, which then further increases the rate of apoptosis of these beta cells. So into a genetically susceptible beta cell, you get inhibition of proper glucose utilization, you get disruption of signaling cascades, a mitochondrial damage that allows the active oxygen species to be activated, activation of the cellular response into them turns this nitric oxide generation. Now remember, nitric oxide is a very schizophrenic molecule. In small amounts, it's extremely protective, but in very high amounts, it's actually very dangerous and is very cidal to the cell. The cytokines also affect the ability of the islet to use nutrients, and therefore you get changed the ability of the beta cell to actually regenerate itself because of the differences in how its intercellular contents have changed. So not only are you increasing apoptosis, you're now also decreasing the ability to regenerate beta cells. And it's very important to keep this in mind. This was all in response to the fact that you started off with some insulin resistance. You had a liver that was trying to work over time. When it failed, you ended up passing this the extra fat on, which caused dysfunction in the pancreas. So clearly, this is what I've just basically told you, that this is how beta cell compensation can no longer, it is overwhelmed, and therefore you get beta cell dysfunction. So prolonged exposure to free fatty acids and glucose contribute to beta cell demise, and you can show this in some animal studies and in some human genetic studies. Glucolipotoxicity is a real thing, and it actually significantly impairs beta cell function. So when you look at the molecular mechanisms that are involved in this process, what you're basically seeing is inflammation, oxidative stress, ER stress, and I throw this slide in specifically because I now want to introduce to you the concept that the medications we use to treat diabetes have specific roles in all these areas. And therefore, what we choose as our first treatment may very well affect the ongoing process of the disease. We may be able to change the natural history of the disease if we can have a rational approach, not only to treating the hyperglycemia, but to using agents that treat hyperglycemia, but also treat the beta cell and the liver. And so, again, I think it's very important to understand it's a vicious cycle. Basically, the liver starts the process off to damage the functional ability of the pancreas. But as the functional ability of the beta cell is impaired, and you get you get further maladaptation of nutrients, free fatty acids, as well as glucose, it feeds back on the liver to worsen liver disease, and then, of course, the concept of cirrhosis. So I think the treatment of NAFLD and type 2 diabetes is so similar that we need to keep that in mind when we start therapy for people who present with new onset diabetes. While there are no pharmacotherapies at the present time that have been fully licensed for use in NAFLD, we know that the medications we use have beneficial effects, and therefore we should start to think about that in that way. So when you approach a treatment program, of course, in early diabetes, you want to talk about hypoglycemia. We're endocrinologists. Glucose is our god. Yes, we'll treat the hypoglycemia. But we have to treat the liver because the liver, in fact, was trying to help out and it got into trouble. And if we can help the liver at the same time as we help hypoglycemia, we're going to go far more. And of course, if you can stop the beta cell apoptosis and even better, allow for regeneration, that's going to be phenomenal change in how we function. So what about metformin? Well, if you look at metformin, it has specific effects on the gut microbiota. It does tend to have some effect on the pancreas, so it is not very significant. It has some effect on the liver, and I'll show you that. And so, yes, we are using a weak sensitizer that works mainly through the liver to regulate hepatic gluconeogenesis, and it might help you lose some weight. When you're looking at liver enzymes over time with people with non-alcoholic steatohepatitis, and you see here that metformin again has a significant benefit in terms of cutting down the ALT, to the extent that that might mean you're ameliorating or improving the functional capacity of the liver. Thiazolidine diets, they've got a very bad name. We don't like them, we don't use them, they're awful drugs. Actually, that's totally untrue. They have a phenomenal benefit. They are true sensitizers, therefore they will make a muscle much more sensitive. They absolutely help at the level of the liver. They have been shown to be of benefit in fatty liver disease, and they have been shown that they have benefit in terms of the beta cell. So if you're going to turn on PPARs, you're going to change glucose homeostasis. We all know that. That's why we use it in diabetes. We also know that it changes lipids. We know that there's a tremendous change in atherogenic lipids. And there's significant increase in the adipokines, there's an increase in adiponectin, there's a decrease in resistin, there's a decrease in FFAs. And it's been shown that this medication, within the confines of the beta cell, forget about where else, in the confines of the beta cell, because of its ability to affect free fatty acid, it actually helps the beta cell to potentially live long. What's the evidence for that? Well, the evidence for that is here when you see the disposition index when you're taking this is significantly better with PZD than it is with insulin. But when you randomize patients with type 2 diabetes for 4 months on TZDs, drug naive, you saw that there was a significant improvement in the beta cell function from baseline as measured by insulin secretion resistance ratio. So therefore, there's clear evidence that you're helping the beta cell. The stuff that was causing the beta cell to malfunction, you're actually reversing that while you're treating hyperglycemia. And you know the ADOPT study, everyone knows the ADOPT study. ADOPT study was taking naive patients with type 2 diabetes, randomizing them to metformin, sulfonylurea, or rosiglitazone, and basically showed that the time to failure was the longest in the people who were on the TZD. So therefore, it's again showing you that this is an attempt to protect the beta cell. Think about this. A drug that we don't want to use, in fact, has an effect on glucose, on the liver, and on the pancreas. Maybe we should think again about what we should do with these TZDs. And one of the things we've forgotten is the dose of TZD. Basically, here's a cartoon that shows that when you use TZDs in different doses, you get a similar effect in terms of the non-glucose parameters. In terms of the non-glucose parameters, you don't get much of a change. But they equal on all three doses. It's only glucose parameters that shows the dose response. And I think it's important to keep that in mind. So therefore, when you use 7.5, which is a very low dose, or 15, look, your body weight is not affected as much. Your BMI is not affected as much. Your body fat is not affected as much. So you're getting the non-glucose benefits without necessarily getting the abnormal benefits that we all attribute to as glitazones. So there is no question that when you think about the beta cell, you have to think about lipotoxicity, autoimmunity, inflammation, islet amyloid, incretins. And we have a boatload of drugs that affect this. We have to use them in a rational way. I've talked about metformin, I've talked about pioglitazone. So what evidence is available regarding the GLP-1s? Well, the GLP-1s have been clearly shown to have clear benefit in terms of glucose, in terms of weight, and in terms of liver fat. Here you see the lean study with liraglutide showing you an improvement in your weight, improvement in ALT, and NASH resolution. Semaglutide has been shown when compared to SGLT2 that it shows significant differences in visceral fat. But more importantly, when you look at the semaglutide studies that were published, there's clear evidence that there's no worsening of liver fibrosis and no worsening of NASH when you use semaglutide. So again, this works for glucose. It works at the level of the liver. Do we have any data about it working on the level of the beta cell? Not really. There's suggestive data that it might, but not really at present significant data to show that that might be the case. So I think it's important to look at the effects of the doses and realize that you do have some significant benefit again on this. Look at the tirzepatide compared to insulin degludec. The story is the same. It's boring. There is clear evidence that you're affecting adipose tissue and you're affecting visceral adipose tissue in a very beneficial way. Okay? Liver fat has clearly been affected by tirzepatide just as much as it has been with semaglutide. So clearly, we have evidence that these are very good drugs, not only for treating glucose, but treating the abnormality in the liver and potentially the abnormality in the beta cell. What about SGLT2s? Well, here's pancreatic fat and liver fat in response to treatment with SGLT2s. There is clear evidence that you're starting to show a decrease in liver fat when you use these agents. Notice the effect on myocardial fat, epicardial fat, visceral fat is not as much. It's mainly in the liver fat that you see the benefit. So when you look at cardiometabolic drugs and consider epicardial tissue as a surrogate marker for all visceral, all ectopic fat tissues, you find that the GLP-1s have a phenomenal benefit. You can see here. SGLT2s have some benefit, and statins show benefit. So when you think about starting to treat someone who new onset diabetes who has come to you, you need to think about what you're going to do. So you might want to start by saying, well, what are the drugs that target glucose, liver, and pancreas? Pioglitazone? Yes. Certainly. Metformin? Yes. SGLT2? Yes. Incretins? Yes, but they're very expensive. Okay? So uniquely in India, you have the potential to change the natural history of this disease, which is an epidemic in your country. It's almost a pandemic in your country. Using combination therapy out of the box may well show the world that this was always the way we were supposed to treat diabetes. That in fact, treating that diabetes that way will in fact help in terms of both diabetes, liver disease, and all the ramifications of abnormal fat and glucose utilization. This is a study looking at metformin, sitagliptin, and pioglitazone in terms of the ability to protect beta cells or beta cell preservation. And you see here that even the sitagliptin shows benefit, statistically significant benefit. So therefore, you have to keep that in mind. Benefit of SGLT2s to the beta cell is again clearly shown. So when you look at these medications, yes, the beneficial effects on weight loss, reduction of CVI events, reduction in CV events, but most importantly, pathophysiologically, you're actually hitting the disease process where it's at. That's what we're doing. Glucose is just a surrogate marker of how good you are doing at the terms of what drives the disease process. So, in conclusion, the liver is a victim. It works hard to overcome the fetal developmental problems, insults of excess nutrition and sedentary lifestyle. It is working overtime to do this. It gives up of itself. It becomes inflamed. It sacrifices its structural integrity and commits suicide in an effort to do the right thing. So yes, the liver is a victim. But I think we have to be aware of that and have to treat this aggressively early with combination therapy. Great studies with combining one drug with metformin has shown some limitation in how long you can protect. Maybe using triple therapy, quadruple therapy out of the box may well change the natural history, and we may actually end up changing what we think of as type 2 diabetes as being a horrible disease as being somewhat less horrible. Thank you very much for your time. I appreciate the privilege and honor of this discussion.
Wonderful, sir. What an awesome session by you, sir, as always. Dr. Amitesh, your comments and any questions you want to ask. In the chat box, we don't have anything, but your valuable comments to sir and whether we want to have some interaction with him. It is difficult to have sir, and it is such a challenge to get him logged in so early in the morning and again give him a challenge of handling technology. But I think everything is worth, because once you hear you, I think that is awesome. That is something which you never get otherwise. So it is brilliant deliberation by you, and it is always wonderful to have you amongst us as a faculty.
Sir, it's a beautiful talk, sir. It was a very complex topic, and you have dealt in a very lucid way. There is no doubt that the liver and diabetes share a very complex and a bi-directional relationship. And I totally favor you and support you in the sense that I strongly feel that pioglitazones are very underused drugs because of the unknown fear or unfound fears which are around actually in reality. And there should be much more use to it because for the number of reasons. And first of all, that they have a long-lasting effect. They work at a level which is slower, but the effects are actually on a long-term basis. In fact, pioglitazone is one of the very few drugs in the world which are also been touted as anti-aging drugs. They actually decrease aging, they decrease renal aging, they help decreases atherosclerosis. So there are so many factors associated with that. But having said so, sir, I have just one or two queries. We do know that lipotoxicity remains the key to the pathogenesis of type 2 diabetes. And But there have been studies where they have been shown that the pancreas could be a better marker of pancreatic lipotoxicity, and that can work as a better surrogate marker of lipotoxicity, and that can be easily studied by endoscopic ultrasound. So can this be another way of looking at the things rather than just looking at the MSLD, which we have been traditionally doing by doing the routine ultrasound?
No, I agree with you, but I think basically what we have to deal with is diabetes, as I said, is an epidemic proportions. The more we increase in terms of procedures, the more we increase in terms of expensive tests, the less likely we are to use. I think we have to use the cheapest tests available so that we can affect the biggest number of people that are with this disease. So I tend to be a little less aggressive about doing investigation of this. I believe in the pathophysiology because it's been very well shown, and try and target. And again, I think basically our ability to target is phenomenal. And I have to admit that in the US, we don't even have half the ability that you have to be able to target this disease in its at its nutshell, at the very core of the disease. And that to me is just a very important advantage you have.
And just another thing, sir, the journals are swamped with studies which shows the safety and efficacy of anti-diabetic drugs, especially in patients with liver disease. As we know that MSLD is actually a spectrum which ranges from a simple fatty liver to actually eventually may lead to even hepatocellular carcinoma. So, but what is the status as far as on treatment of liver disease which can have effect on the diabetes?
Okay, so you bring up a very important question. Basically, once you start getting into a liver that's really starting to fail, a lot of these medications, I'm not saying they're contraindicated, but we don't know what they would do. And that's, I think, the more important point. Okay? It's important, therefore, to sort of keep in mind that the earlier you get into this, the better off you are in the long term, and you can actually prevent this. And so from that point of view, I feel very strong. One of the things about NAFLD, and I couldn't attend your talk, the earlier talk on MASH, everyone talks about fibrosis as being an endpoint. But think about it. How do you expect the liver to heal? Think about if you are going to take fat away from the liver cells, they have to heal. How are they going to heal? They've only got two choices to heal. They can either regenerate, which is very difficult, or they can fibrose or scar up. So to use fibrosis as a measure of success, to me, makes very little sense. If I'm doing very good in terms of getting the liver to free of fat, then I either expect the fat cells that are destroyed to either regrow or to fibrose. So fibrosis as an endpoint, I find it as a little bit more difficult. What's most important is look at what happened when you use an antifibrotic agent, specific antifibrotic agent,
yes,
an aldosterone blocker, mineralocorticoid blocker. They have shown no benefit. Why would they show benefit? You have to expect fibrosis to occur because there's nothing else the liver can do to heal itself. So I don't know how much weight we should put on the fibrosis. We should look at the lack of ballooning, the drop in liver fat. Those are markers that make sense. Fibrosis hopefully is not advanced enough to cause cirrhosis, but if it is there, it's not going to go.
Okay. I think an advanced fibrosis has picked up on fibroscan, which is a 10 today as a standard care, possibly cannot be reversed. I absolutely agree with you. It has to heal with fibrosis. Any wound or any inflammation will heal with fibrosis. Only thing is, if it is early, even with pioglitazone in PVN study, we have seen it.
Right.
Even with SGLT2 and even with the semaglutide or other GLP-1 receptor agonists, some amount of regression of fibrosis or slowing of fibrosis has been documented. So it makes sense, I think, when you say out of your prudent practice that these drugs use little early to carry on that process. I'm not saying they are antifibrotic, except the drugs like GLP-1, which have shown little improvement in fibrosis. None of these drugs have reversed fibrosis. So again, that has to be taken with a pinch of salt. Earlier effort to prevent that steatosis and then going into inflammation towards fibrosis probably will be the best approach. What do you say, sir?
Absolutely. And something else that comes up all the time, this comes up every time I talk about this. people talk about the fact that South Asians or Indians seem to be more prone to side effects from the GLP-1s. I will tell you this. When I see a patient with a GLP-1 side effect, I know that the goddamn drug is. And if it shows me a side effect at a lower dose, that means it's working at a lower dose. I'm not so sure that pushing the dose is absolutely necessary. We have surrogate markers that says that the dose that you're getting, that you're tolerating, is working. Sometimes instant gratification is only for children. We might want to wait a little bit as we say, wait with pioglitazone. And I think we should be able to be a bit more patient, and we'll find that these benefits will accrue, but it takes a more longer time. So I don't have any compunction about using East Indian patients or Indian patients and putting them on lower doses of this. I have lots of patients on the inception dose of semaglutide because they can't tolerate the regular dose. The East Asians, South Asians, sorry, they are basically relatively smaller people. They don't have the BMI. They have the visceral fat, but they don't have the BMI, and they seem to require a lower dose. I don't see that as a problem.
Unfortunately, Professor Dindona is not going to join. I'm told he's suffering from COVID. Fortunately,
Oh,
he's
dear.
stable, but
I
he
was
said
looking
that
forward to talking to him.
yeah, he said I'll not be able to do session this time, that too early in the morning at Buffalo. So we have to excuse him, but of course we put it on records that we are missing his presentation every year. We have it clubbed with your presentation because we don't want to get you say up very early in the morning, more so Professor Dandona. So I think thanks a lot. It is a wonderful session. We express our gratitude to you for not having done a wonderful session, but also having get up early in the morning to do this session and be part of our conference year after year. Unfortunately, every time we miss your physical presence because you come for Dr. Makkar's conference, which happens to be 3 weeks prior to that. And no way I understand that it is possible traveling twice a month from such a distance place. But I think your deliberations have really contributed to popularity of our CMRE ASD International Symposia. This is 11th in the 11th edition in the row, and we had a wonderful deliberation from ASD, 5 speakers, Professor Inas, Professor Mohammed, Naveem, Garmila. Everyone did a wonderful job. After that, we could have Professor Colin, Professor Antonio, and of course, your deliberation all were awesome. So thanks a lot. I think we must express our gratitude to all the delegates, those who have logged in till late. I'm told that even at the last session, we have close to 900 some delegates still
Oh,
glued to the
that's
screen
wonderful.
to hear you people. That talks about your popularity in this part of the world. And thanks a lot, Dr. Mitesh, for being with us so late in the night. So
Pleasure
we're
is
here,
mine.
we will log in with our expression of gratitude to all the entire international faculty, our own chairpersons. Tomorrow we will log in again at 3 p.m. sharp for a DIPSI symposium for three hours, 3 to 6, followed by a face-to-face physical meeting, which we have for the first time with ACE CMRE Joint Symposium starting at 7:30. So all those who are in Delhi, those who are logged in, we request them to make it tomorrow also. And Sunday we have a day-long 9 to 5 o'clock. Both the halls having simultaneous. So we are going to have close to 30 sessions from 9 to 5. So I'll request everyone to make it tomorrow in the evening also. Log in for DIPSI Symposia, which is 3 hours, 3 to 6 p.m. And on Sunday also, be with us from 9 to 5. Thanks a lot. Good night, everyone. Stay safe.
I'd like to
And
thank you
thanks,
guys.
Professor
Thank you
Arif,
very much.
once again from
Appreciate
bottom
it a
of our
lot.
heart. Yeah.
Thank you for the invitation. It was wonderful. And I hope that
Thank you. Thanks a lot.
Thank you, sir.
Thank you.
God bless you.
Thank you
Nice,
so
sir.
much,
It's a
sir.
personal
Thank you,
obligation.
everyone.
Thank you. Thank you,
Thank you.
Dr. Mitesh, Dr.
Thank you,
Meena.
sir. Thank you so much.
Dr. Meena was
Thank you.
there right since
Yeah,
beginning
she
when
just
we
left.
started
She just
actually.
left.
Really, thanks a lot, Dr. Meena, and most of the people, those who were
Thank
there
you,
throughout
everyone
that.
who's logged in, and see you tomorrow. Thank you so
Thank
much.
you.
Good
Good
night.
night, everyone. Thank you.